feel?
Not good.
Hard?
Yeah.
Where do you think things went awry as far as it being hard? Was it question type? Was it not what you expected? If we have time at the end of class, I have a slew of questions I've written down that I'm going to go back and review them anyway. But if we've got time, I'd like to kind of get your guys' feedback on them to see.
Can you look at the later ones too? I thought they weren't all of that.
Which one?
The later ones? Yeah, the questions that we did.
Which one, like what specifically? Because there were a couple that talked about the position of the baby that we did talk about.
It wasn't the position one. One was like the -2.
Okay. We did talk about that. That had to do with fetal station. Yeah, that was with the ischial spines and where baby was, positive and negative. That wasn't labor specific. That was just where baby's sitting. So we touched on that at the very end of class last week. That positive is on its way out, negative is it's floating. So a +5 baby would be right, ready to go. There was one or two specifically that I looked at that were the question itself had a ton of details in it, and it was one of the ones in particular was talking about a fetal abruption, and it doesn't say that. It gives you all the symptoms for the placental abruption and asks you what to do about it, and the majority of the class didn't get it right, so I want to go through and figure out kind of why you guys picked what you did so I can figure out whether or not I'm going to make it a bonus or throw it out or give credit back or kind of what I'm going to do. There's a handful of those questions that I jotted down. Basically, the way I look at exams is I go back and anything that like 40 to 45% of you guys got right or less, I go back and review those questions because that to me says something is up. Either it was a really hard question, which there are some of those, and the statistics will tell me that, in which case I tend to leave the question as is because there should be some in there that are on the more challenging side. But anywhere it's telling me either it's I didn't cover the content enough, or it was a poorly written question, or maybe there was conflicting information in the book versus what I said, or something to that extent. Those are the kind of questions I want to know about, because then I'll go back and either throw it out completely. There were 3 in particular that I already know, one of which I've turned around and made into a bonus, like I just got rid of it because nobody got it right. And it's something that tells me that I didn't cover it thoroughly enough, is my guess. The one where you have to put the order in for the menstrual cycle. Yeah, that one, it's gone. Already it's gone, because not a single one of you guys got it right. So it was the order that it was in. Yeah. There were a couple of you guys that flipped like one of them, and I was wondering if it was because you were like, well, it can't just be the way she gave it to me.
Exactly, that's what I looked at.
Yeah, it was. But that question's gone, because clearly it messed with you guys, and that's not fair. So you'll notice when the grade comes out, it's going to have like a weird percentage point, because my thought was, rather than going back and giving every single one of you guys credit for the question, which just gives you all 1 point back, what I did was instead I made it into a bonus, and so the whole exam is now out of 49 questions, even though on your grading system it'll still be out of 50 points. So what that does is it weights every other question just a little bit more, so every one that you got right is more like 1.1 points rather than just getting 1 back. So as long as you got a 10 on the exam, giving you that way gives you more value than by just giving you the point back. So that one, and it was the other 2 on either side of it. There was one that we're going to talk about because I want to find out exactly. I already know where the discrepancy is. The one about what would you test for on that particular patient. It was a select all that apply, and it was pertaining to the glucoses. We'll get to it if we've got a chance, because that one I've given credit back to some of you guys that I can see based on my PowerPoints already. I had a feeling that was going to offset you. So that one, and then I can't remember what the other one was right around it.
Which one did you say that was? That was, I think, the temperature that we're going to talk about.
It was like ruptured membranes, fetal anomalies, blood glucose. We're going to go over that one, because that one I gave credit back to some of you guys based on where on my PowerPoints I can see why you picked what you did. I haven't had time to go through every single one of those questions because I basically wait for you guys for the majority of you guys to get done before I start even looking. But at least it gives me a vague idea, and I kind of just went through really fast at the end to figure out which questions I'm going to need to go over, and then I can cover those with you rather than going over the entire exam. And what I'll do is after I've got the grades up, I'll make the exam available to you guys so you can go back and look at it and see where you went wrong, and what the feedback should provide will say like where in the chapters the answers were to that particular question so that you guys can go back and look at it, rather than us taking time out of class to go through every single question. Does that seem reasonable? Yeah. Okay. In that case, you've got to bear with me over the next couple of hours so we can get through the new content, and as long as we get that done early enough, we'll cover the remaining couple of questions. Okay? On the quiz, class average came up to an 80, so up just a tiny bit from where it was the week before. I know, I can see it already, that where a couple of us struggled, or it's more the type of question and reading it than anything else, because where you guys lost points for the most part are in very similar questions. So question 1 was talking about assisting the physician with a physical exam, talking about the definitive diagnosis of pregnancy. The only one out of all of those that's 100%, there is no other justification or explanation for what is going on, is hearing fetal heart sounds, because nothing else is going to make that sound. Gas isn't going to do that, tumors aren't going to do that, hormones aren't going to do that, whereas all of those other things can be justified away by something else. Does that make sense? That one was more of a knowledge-based question. Talking about a gal coming in for her first prenatal visit. They're doing a complete physical exam. They want to know why that's required. Ultimately, we talked about the fact that the health of mom is what determines the health of baby. So we have to do a complete physical exam because there's no other way for you to know the health of mom. It is important when you look through some of these other questions, when we look at responses, this is a requirement for all newly pregnant women. Well, that's true. Does it explain why? No. And when you read it, it says because the doctor wants to learn as much about you as possible. Well, that's true, but doesn't really still explain the purpose of the complete physical exam. While it's not a wrong choice, there is a better choice available. And then the doctor wants to make sure that the baby's healthy and that your pregnancy will progress without complications. Well, it's true. The doctor wants to make sure that the baby is healthy. However, does doing a complete physical exam have any guarantee that that pregnancy will progress without complications? I would love to say that we can guarantee that of somebody, but you can't. You can't ever make that promise because things happen. If they got hit by a car on the way out of the parking lot, would having done that complete physical exam have prevented that complication? No. So again, just kind of making sure that we're thoroughly reading the choices and the options. This one, when we talk about preventing neural tube defects, nutrition is going to be something that comes up on your boards quite a bit. It came up on your exam a fair amount, and I think we probably, as a class, didn't talk a ton about it, although I did reference the text a fair amount, and maybe going forward we'll make sure that when it comes to nutritional stuff, we're delving into it a little bit more. Your boards are going to stress this. It's an outcome that's an expectation per the state for you guys to be good at nutritional support and guidance and expectations. So making sure that when we're talking about things like increasing iron or increasing different types of foods, that you know what those types of foods are. That's going to be key for you guys. So when we're looking at things like folic acid, we did talk about this last week when we mentioned the fact that how the FDA basically instills or requires companies to put things like folic acid in a lot of different foods. And the number one things that we see them in are going to be cereals and bread, right? So when you look at this question, you need to find the answer that has the most items that are going to have folic acid in them. And you can see, based on the division, that you guys were pretty evenly split as the class went. Cereal with milk and peanut butter on toast. Cereal is a carb. It's going to be a bread-like product. It's going to have folic acid in it. Now, one of you guys, as I was talking earlier, brought it up that technically, per research, per information, it's got to say fortified in order to include folic acid. And that's true, but you'll notice none of these options say that. So you've got to use the information that you're given. So in this situation, you've got cereal with milk, so you've got cereal number 1. Milk has some folic acid in it, not a ton when you're looking at the grand scheme of things, but you've got cereal for 1, peanut butter, some brands put folic acid in it, and then toast. You've got 2 items within that category that guaranteed, hands down, have folic acid. When you think of folic acid, if you think of carbs, like bread-type carbs, that's going to be your easiest way to kind of rule out all the other choices. For the rest of you guys that picked peanut butter on toast, okay, well, we've got our toast, so we've got 1, but we don't really have much else. Orange juice sometimes has some, but not a great source. Folic acid, for the most part, is going to be your green leafy vegetables, and your high-density carbs are the ones that get fortified with it.
I looked it up.
Mm-hmm.
It says citrus or juice has folic acid.
And it does. So I'm not saying it doesn't have it, but you're looking for the option that has the most. And so the heaviest products are going to be your green leafy vegetables and those carbs. And because that last choice has 2 components of the carbohydrate, you're getting it twofold. Does that make sense? That one is probably the one that tripped the majority of you guys up that didn't get 5s, that got 4s. My guess is that's the one that probably got a fair amount of you guys, because it wasn't straightforward. It's something that you do have to kind of think through to get to the answer. Question 4. This is the one that I'm going to guess was we didn't read this carefully enough question. So you've got your patient with hyperemesis gravidarum. That means that what? Right. Lots and lots of puking, right? Which statement by mom tells us that further teaching is needed? So that means that we're looking at this question to find what? What's got to be in one of these answers to make sure that it's the right one? The wrong one, right? So I will sip water throughout the day. That's a good thing, right? We need to make sure that they're staying hydrated. What's one of the biggest things that we educate them on in order to prevent them from puking a lot? Not to eat big meals. So if we're gonna sit down and drink fluids, which we want them to have, important to stay hydrated, they probably should do it in small increments throughout the day so that they're not throwing it right back up. So saying I will sip water throughout the day is a great thing for them to say, because that tells us that they are listening. I'm going to guess that those of you who picked that probably saw it and said, absolutely, and grabbed it. I'm glad to see that you guys felt like they probably should call the provider if there was blood in their vomit. I would hope that should be something that everybody should alert their provider of, regardless of their state. I will be sure to eat 3 good meals a day. Well, now in theory, that sounds like a great idea for every patient, but when you look at this one in particular, we don't want them eating 3 big meals a day. We want them eating lots of small meals throughout the day so that they're not puking back up these huge meals. So that's why that's the correct answer. Does that make sense? Well, so as far as spicy or fatty foods, those are the kind of things that are going to trigger them to puke. So if they're going to say, I won't eat spicy or fatty foods till I feel better, that's a great thing for them to say. That's completely right. So yep, makes sense. So be careful, because I really like looking through these kind of questions. This tells me that you guys all know the information. You're all giving me the right answers. Sitting here, you're giving me the right answers. Pick the right answers at home. Yeah, I will tell you, look, because I get to see how long it takes you guys to do this. Most of you are done in 10. You've got time. Take your time. It will benefit you. I know that ticking time clock drives a lot of people crazy. Cover it. If it's bothering you, if you feel like it's making you anxious about getting your answers in, grab a piece of paper and tape it over the corner of the screen. Do whatever you have to make it beneficial for you guys. Because obviously, these are the points that should be easy for you guys to get. The exam, that's tough regardless, because you don't have your book, you don't have your resources, you don't have the comfort of your own home. You've got the pressure of, it's a big score. These should be the easy points for you guys to get that will help to buffer your grades as the semester goes on. So whatever you need to do to get good grades on these quizzes, do it. If taking that over, if the clock is what's driving you crazy, cover it. Don't worry about it. Because going over this in class tells me you all know this. Okay? We just have to get that testing strategy down, because that's not going away. And then the last one, as far as the prima gravida in her second trimester, planning a long driving vacation, you all got it right. So, yay. Getting up and walking around, moving every 2 hours is going to be key. So, good job on that one. Is there any questions on the quiz? We're good? Okay. There will be a quiz on the material we covered today, so make sure you don't forget that, because a lot of times having the exam tends to throw people off. So make sure you take that. By the mid, oh, what did I do? Yep, yeah, same as it's been. What the heck is going on? Play. Oh, good golly. How?
We're like 10 from 10.
I know, I'm trying to figure out what the heck. There we go. Okay. I was like, I don't know what happened. Why do I have... Okay, so we ended on that positioning of the baby, right?
Yep.
So when we were talking about that fetal station, that's the plus or minus that was in the, that was here, this fetal positioning, when we were talking about the fetal station and where they fall with the ischial spine. Okay, so uterine contraction. So now we're talking about the P of powers when it comes to delivery or labor. And there's 3 different phases of a contraction. There's the increment, which is the period of increasing strength, so it's building. You've got the acme, which is the peak, and the decrement, which is the point of decreasing strength. So basically every contraction is going to create this nice big wave pattern. It's important to note these different phases of the contraction because there are certain things that happen during each of these that are considered normal. So for example, when we start looking at fetal heart rate, we expect them to change based on which phase of the contraction they're in. We expect the fetus to react appropriately. Well, if you start seeing different changes in heart rate that you expect at one point and they're showing up at another, it kind of tells us that there's something going wrong. So it's important for you to at least understand the concept of how the contraction happens. The frequency of the contraction is the elapsed time from the beginning of one until the beginning of the next. This gets to be important because when we're talking to families and we're telling them, educating them on true versus false labor and when to come in and how to know whether or not it's time, one of the biggest education pieces we provide them is how frequently are you having contractions? We have to know that they're counting them appropriately, and that means that a contraction starts, time clock starts. That contraction comes and goes, and we wait now until the next contraction starts. A lot of times people come in thinking that they're contracting every 2 to 3 minutes, and what they're measuring is the time in between contractions. It subsides, now they start timing it, and 2 minutes later the next one starts. Well, it may be that their contractions really are only 5 minutes apart when we start looking at it in the appropriate timing of start of one to start of the next, and it tells us very much about what stage of labor they're in. So it's important to make sure that we're counting them appropriately. If contractions get to be closer than 2 minutes apart, so start of one to start of the next, we start to worry because what happens is during a contraction, that uterus clamps down and it cuts off or diminishes the supply of blood to baby. So if it's diminishing the supply of blood to baby, it's also diminishing the supply of oxygen to baby. So if we have a contraction, and that contraction relaxes, now that baby gets a nice big rush of blood, a nice big rush of oxygen, and kind of replenishes the supply that we diminished during the contraction. That's normal. So we expect to see. If you end up with 2 contractions way too close together, now that catch-up time is really short. So we worry that if contractions get too close together, that now baby's not getting enough oxygen. Again, one of the reasons why we need to understand how to count this stuff. The duration of the contraction is the length of time from the start of a contraction until its end. Again, if that contraction now lasts too long, we talked about what happens during a contraction, right? What happens to baby's oxygen and blood supply? It goes down. Well, if that contraction is lasting longer than it should, baby's supply is now compromised for a longer period of time. So if that contraction lasts more than 90 seconds, again, we start to worry about how baby's going to respond, how baby's going to react. Did we talk last week about the intensity of the contractions with your nose, your chin, your forehead deal? Okay. So again, there's kind of the reference, the refresher on that. That's really our only way of knowing the strength of the contraction unless we put in an intrauterine pressure catheter, IUPC. And there's a picture of it in your textbook that goes through that fairly well. And what that does is it actually measures the pressure change inside the uterine cavity. That'll give us more of a objective measure of the intensity of the contraction. And then interval. That's the length of time between contractions. What that tells us is how long baby has to recover from that diminished oxygen and blood supply. If that interval is less than 60 seconds, we get concerned. All of these things together basically give us that if the contractions are less than 2 minutes, start of one to start of the next. Because you can imagine if you've got a contraction that's lasting 60 seconds, and you've got 60 seconds in between, there's your 2 minutes. That's that borderline cutoff. We start shifting any of those numbers, and now we've fallen into that window where we're less than 2 minutes apart. Does that kind of make sense? It's typically what we do in that kind of a situation is you put oxygen on mom, because oxygen on mom means oxygen on baby, and you call a provider. Those are your two big ones, because it depends on what else is going on, where your next steps lead. But universally, you've got contractions that are happening too frequently or too long, or you are noticing alterations in baby's heart rate that are concerning. Put oxygen on mom, call a provider, because the oxygen on mom isn't going to hurt, and your next step needs to be getting somebody there who can do something about it. It just depends. It kind of depends on what else is going on and where baby is in the delivery process. So, mechanisms of labor. This is the actual physical process that baby is going through to come out. This is the ideal scenario. This is not always how it happens. But this is the way the body is designed to function. So the first thing that we see, and I'll kind of go over this again, standing up there with a discussion of kind of how the words match up with the pictures. So the first thing that we see is descent. So baby descends through that pelvic cavity. Then we see engagement. Engagement means that baby's at what station? What's the number that's associated with that?
Is it 0?
Yeah, there we go. 0. So if it's at 0, officially engagement has occurred. If it's at 0, that means that baby's head has met that imaginary line between the ischial spines. Once baby has engaged, the next steps that we see are going to be flexion. So baby flexes. They do an internal rotation, and then they extend themselves underneath the pubic symphysis. And again, I'll kind of walk through all of this alongside the pictures. Restitution is the next stage, which is where baby now rotates itself as it's out. You know, the head is out, and as the shoulders and body follow, the baby rotates. And then we see expulsion of the baby, so baby officially gets delivered, head to toe, followed by placental expulsion. So that comes after. So what we see when we look at the pictures, I wish I could figure out why this is, but what we see is baby is descending down into mom's pelvic cavity. Baby gets engaged into that pelvic cavity. We've got him at station 0. We start to see them flex. You can see baby's got that nice tucked position. With that tucked position, we start to see an internal rotation. So, and you can kind of see it. You see how baby's facing sort of anterior. Now baby's facing that vertebral column. Baby's completely facing the vertebral column. So internally, baby starts out facing typically one of mom's two sides. Remember when we were looking at that positioning, we had that left or right as far as our fetal position goes internally. So they're descending, we get engaged, they start to flex into that nice tight position. Baby is making this rotation so that the face is against that vertebral column, because the face is nice and squishy. The face against the vertebral column is much more comfortable, A, for mom, and it's designed that way so that it will kind of mold and and make the process go much more smoothly. When you have a baby that's OP, that's occiput posterior, now we're talking a baby that we call sunny side up, and this part, they're split. And so what they have against mom's vertebral column is actually that occiput, the back hard part of their head. So with moms, they end up in what's called back labor, and it hurts. It hurts more than any other part of the entire process, because what they're doing is they're getting that baby's head just pounding on that vertebral column as they're trying to get up and underneath the pelvic bone. Not a pleasant delivery. Doesn't mean they can't deliver vaginally. Plenty of people do. But there's a lot of nursing interventions that go into a baby that's being delivered OP to help the process. Not something that we're necessarily going to cover for you guys, but just something to be aware of, that there are interventions that we can do that are non-medical, like they're positioning and things like that we can help with to aid the process of labor. So we've got baby nice and flexed, they're internally rotated, and now what we do is we jump up here, and you can see that as baby's coming out, they have to extend. So you've got this nice tucked baby. They get to the point where this part of the occiput of their head is now bumped up against mom's pubic symphysis. That pubic symphysis is not going to give way. It's not going to just move itself, right? It's a nice firm bone that's designed to be there to hold that whole pelvic cavity intact. So what baby has to do is it's flexed like this. It now actually does like a swan dive underneath that pubic bone. And the occiput itself comes down and baby extends, just like in this picture, up underneath the pubic symphysis. If a baby ends up in a shoulder dystocia situation, which we're going to talk about here in just a little bit, this picture is kind of your understanding of why we do the things that we do as a nurse, because one of the interventions we are assisting with is what's called a McRoberts maneuver, which is basically as the OB is trying to deliver this baby and the head is outside and the shoulders are stuck, the nurse basically slams down above mom's pubic symphysis to pop baby up and under. Oh yeah, they're really pleasant to watch too.
I wouldn't hurt the kid in that?
No, because what they're pushing on is here. It's all the soft tissue. It's just enough to basically, it's when their shoulder gets stuck under that pubic bone, and it basically does this number, and it like pops their shoulder forward across their body and tucks them so that they can get out and under. But it's not gentle by any means. So we get extension. Now it's called restitution. So if you look, as this head has come out, it's a nice big circumference. The problem is, baby shoulders, just like everybody else's shoulders, are wider than their head. Even if you turn your head sideways, this distance is still going to be narrower than this distance. So in order to get their shoulders to come out, what happens is they start this rotation, and it condenses their shoulders like this to make it a much smaller diameter, and it compresses them down. And as they're rotating now, those shoulders should come out fairly easily. So they start to do this restitution. So when they're first delivered, you can see baby is face down towards mom's butt. And as they rotate around, now baby starts to come to the side again and look up as they're delivered the rest of the way. Babies that are OP, that are born sunny side up, start out face up. They don't ever necessarily go through this restitution phase as drastically as a baby that is delivered AP, which is ideally what you would want to see, or OA, occiput anterior. Does that make sense? This is how the body is designed to deliver. That doesn't mean this is how it always happens, but this is the way that it's supposed to progress, ideally. It's what we like to see because that's going to be the easiest delivery. So, yeah.
So in this ideal delivery, baby starts through that passageway face down, and then they turn out, like you said, sunny side up, they come face up.
So they start out face down on their way out,
Yeah.
and they turn to be sunny side up. Yep. If you get the opportunity to see a delivery, or if you guys want to YouTube it, a lot of this kind of stuff, you can see this whole process actually happening on those videos. I tried to find a really good one that would work, but I couldn't find one that wasn't like 15 minutes long where I'd have to sit there jumping around trying to find the point of actual delivery. So, premonitory signs of labor. So these are the things that we're going to be looking for that tell us that labor is imminent. It's going to be coming soon. Lightening, we talked about last week a little bit when we were looking at the measurements of the fundus to know how far along baby was. Remember, at 36 weeks, that fundus was up in mom's rib cage, and at 40 weeks, it had dropped down a little bit. That's that process of lightening. And what's happening is engagement occurs. So that baby is dropping into that pelvis. It's getting to station 0. And now that fundus is no longer pushing on the diaphragm, and mom gets a lighter sensation. She feels like she can breathe. However, with the easier breathing typically comes the urge to urinate far more often, because now baby's locked in that pelvis. You remember where the bladder was positioned in relation to the uterus, right? In front. So if that baby's now locked into the pelvis, where do you think that pressure is being put onto the bladder? Pushing that bladder right into that pubic bone. They also tend to get leg cramps and lower extremity edema more so than they had, because what happens is as that engagement occurs, now that baby's also compressing the femoral veins and arteries, and so they're getting cramps because they're not getting blood supply to their lower extremity muscles as well, and they're getting edema because they're not getting venous return because the baby's blocking it. So it's one of the reasons why we educate women about getting their legs up, putting their legs up, elevating them at the end of the day to promote that venous return, to get baby up and off of those vessels. So, again, when you're looking at reading through your questions, when you have a patient that's at 20 weeks gestation with edema in their legs, is that normal? No. If you have a patient that is 38 weeks with edema in their legs, is that normal? It could be. So just kind of things to keep in mind when you're reading through those questions, making sure you know how far along your patients are, because that impacts whether things are normal or not. Bloody show. That's it's the mucus plug that's blocking that cervix that we talked about earlier in the semester. And what happens is it becomes dislodged from the cervix itself, and because of the fact that the cervix is highly vascular, as that plug pulls away, it's tearing small tears in the capillary beds, and so that's why it's slightly bloody. It's pink tinged. It's caused by the increase in pressure from that baby engaging. Again, we've increased the pressure down in that cavity, and when you've got high pressure and low pressure, where's the plug going to go? It's going to go to low pressure. So it comes out. Oftentimes, women will describe a increase in energy level that they'll attribute usually to being able to breathe a little bit easier, but it's also hormonal. And they tend to get a sudden burst of energy about a day or two before labor, and you'll notice that they do what's called nesting, and they clean everything. They just get this urge that the baby's probably going to be coming soon. I should just make sure that the walls are bleached, because who's bleached their walls in their lifetime? Not me, for one. But you hear about people doing those kind of things when they're getting close to labor. False labor is important to distinguish from true labor, because people need to know when to come in for evaluation. False labor, we do not see cervical changes, and the contractions are irregular. Braxton Hicks contractions are part of that false labor process, and it's normal for people to feel Braxton Hicks contractions throughout the pregnancy. They begin very early on. You remember we talked about the fact that those are what help that placental blood flow, that peristaltic motion, to help that blood get into the to the placenta, and then baby's blood to be able to circulate through. They do play a role in prepping the cervix for dilation, kind of shifting baby around in there. The important thing to note is that false labor contractions get better if people sleep, if they lie down. They also get better if they're up and walking around. True labor does not. Those contractions don't stop regardless. So important to note that and it's usually an education piece. People will call in and they'll say, this is what my contractions are doing, this is what I'm experiencing, and we'll tell them, okay, well, have you tried lying down and putting your feet up for a half hour? If you have and they're still not going away, come in. If they've gotten better, you're not in labor. The other component to that, sometimes there won't be bloody show, and typically with false labor, the pain is localized to the abdomen, because what's contracting is just the muscles of the uterus. So their pain tends to start and end in their abdomen. With true labor, the pain may start in the abdomen, but it tends to radiate around to the back, or it'll start in the back and radiate around to the front. So those are kind of your big cardinal differences for true labor versus false labor.
So then, like, you know those videos you see of, like, moms dancing and, like, is that a false labor that they're experiencing, or is that?
So it can. It's something that people will use as a coping mechanism because they're not trying to dance away the contraction. It's more of a distraction than anything else. And then when we start looking at their water breaking, SROM stands for spontaneous rupture of membranes. You'll see abbreviations like this. The other one that you'll see will be AROM, which is artificial rupture of membranes, which is where the OB ruptures them, usually to help progress the labor itself. A couple of things that we need to watch for with spontaneously ruptured membranes. One, if labor doesn't start within 24 hours, our big number one concern is infection. Because you remember that amniotic membrane was what protected baby and the placenta from an ascending infection, right? The vagina is not sterile. It's a hostile environment, but it's sure not sterile. So, yep.
And this is, so labor must start 24 hours after the plug or 24 hours after the water break?
After the water break.
Okay.
Yep. So one of the things that you'll see, and this is a big variation between hospital medicine and midwife medicine in like a birthing center or home birthing, there's nothing that says you have to induce labor 24 hours after their membranes have ruptured. It's highly recommended. It's something that per the College of Gynecology and Obstetrics, that's one of the guidelines that they practice under because of the elevated risk of infection, but that doesn't mean that they have to do it. So a lot of times birthing centers, home births, things like that, they'll allow them to go longer. Because just because their membranes have been ruptured for more than 24 hours does not guarantee that they'll have an infection. It just increases the risk. The other thing that we need to know about, and this plays a role especially for you guys that are going to be practicing in the outlying region, you know, how if you're going to be in the ER setting, if you have somebody that comes in and they say, my water broke, regardless of the rest of your scenario, the very first thing you do is you check fetal heart tone, always. It's probably one of the few absolute alwayses you can guarantee on for your board. Because the number one thing that we worry about with ruptured membranes is if they happen to rupture and baby hasn't completely engaged into that fetal station 0, there's a chance that baby's up and floating around and that cord is up and floating around, and when those membranes rupture, that cord slips in front of baby and is now coming out and baby's head locks down on top of that cord. When baby's head locks down on top of that cord, what do you think is happening to baby? No oxygen, no blood supply. Your number one indicator to know that's happening is fetal heart tone. Fetal heart tones, fetal heart rate is always going to be your best indication of what is going on with baby. So regardless of where you are, regardless of whether you're practicing up on the OB floor or in the clinic setting or in the ER in Chodo, if somebody comes in and their water has broken, your absolute number one always answer is fetal heart tone. Always. Now, the other thing that is important to note is that people aren't always very accurate when they come in and they say, I think my water broke. We see a ton of people in triage up on the OB floor who think their water is broken and they feed themselves. Or they had sex and some semen is dribbling out. Or they have increased vaginal discharge because they're pregnant. You laugh, but it happens all the time. So, in order to differentiate between semen, vaginal fluid, urine, or ruptured membranes, one of the tests that we can run is what's called a nitrazine test. And all that is a dip. It's like a urine dip, basically. It's a pH strip. If it turns blue, it is alkaline. It's amniotic fluid. Everything else will stay pink. If it's borderline and isn't really clear cut, then we can do what's called a Fern test, which is where they take a sample of that amniotic fluid, they let it dry, and they look at it underneath the microscope, and you can actually see the amniotic fluid when it dries creates a ferning pattern like the leaves on a fern.
But if someone comes in like from their house, like,
it will still be leaking. It doesn't just like gush and it's gone. It will continue to leak. It typically, if somebody comes in and they have a thong on with a tiny little panty liner, their membranes didn't rupture. Usually a pretty good indication, because if that's the case, their legs would be drenched. There are times where people will start to leak gradually, but those are not the people that typically come in. Those are usually the ones that are getting symptoms, and then they come in and it turns out they've been ruptured for 2 or 3 days because they've had a slow trickle rather than the big gush. I will tell you, not everybody recognizes when their membranes rupture, because for some people, especially if they have polyhydramnios, too much fluid, it's a huge gush. For some people that have oligohydramnios, so not enough fluid, it's a smaller gush. And it could be that they peed themselves. You know, there are a lot of people that say, well, I just didn't come in because I thought I sneezed and I leaked. I took care of a 24-weeker not that long ago, and Mom sneezed and her water broke. And that's all it took. So there are kind of scenarios there that take a lot of education on our part, and a lot of people, I feel like, in the general population don't really get educated very thoroughly on this. However, if you receive a phone call, it is not on you to decide over the phone to triage them, whether they peed themselves, whether their water broke, or whatever it may be. If they say, I think my water broke, your answer always is, come in. Always. Because God forbid you make the wrong call and their water broke and now they are sitting at home for 48 hours and they come in fully septic, we've got a much bigger problem. So it's not a big test. It's not something that takes very long. We do it all the time. Have them come in. Have them come in. You do the nitrogen test. It's pink, you send them home. It's blue, they're not going anywhere. They're having a baby, at least in the next couple of days. But typically once their membranes are ruptured, we want them in the hospital setting or in the birthing center or whatever it may be that their choice is. Does that all make sense?
What are the reasons why the water would break?
What do you mean?
For people who end up doing the cramp scene and they have the pain, and go in and then end up being like, well, you're this far dilated, but we can't get your water.
Yeah, it's just a natural deviation in the process. Sometimes it may be that baby's not engaged. They may be that dilated. They may be starting to contract regularly, but baby hasn't actually descended enough to create enough pressure to rupture their membrane. Some people their membranes will rupture before they're ever cramping. It just, again, it's kind of a deviation in how their body reacts to pregnancy. Size of the baby sometimes will do that too. If there's multiple babies in there, those sort of things. So, stages of labor. There's technically 4 stages of labor. The first stage is the longest, and it's broken up into a couple of different phases within the stage. It starts with the onset of regular contractions. So again, distinguishing false versus true labor. True labor, we've got regular contractions. That's the start of it, and it's complete when the cervix is fully dilated and effaced. Those are your markers for when it starts and when it finishes. There's no other symptoms that go along with it. I don't care what their dilation is. I don't care what their effacement is at the beginning. All that matters is regular contractions, and at the end, I don't care what their contractions are like. All I care about is that they're fully dilated and fully effaced. Remember, dilated is this way, how far open that cervix is, and effaced is how much it's thinned out. It starts out nice and thick. It effaces, it gets nice and thin. So, the latent phase is the very start of this first stage. The length of it can vary. There's nothing that predicts exactly how long this takes. Some primate women, so first pregnancy women, it could take 20 hours. It could take longer than that. It could take less time than that. With people that have had kids before, it usually ranges about 10 to 12 hours, but again, that's not something that's tried and true. You would never tell somebody, well, how long did your labor last time? Okay, well, it'll last X amount of hours less this time. You'll hear people that will say that. Oftentimes, patients will come in and they'll say, listen, I know, I just want you to be aware, when I get to the point where I'm starting to progress, I progress fast. And that may be their personal deviation, and I would go with it. I would believe them on it. but you don't typically advise people that that's how it's going to go. Instead, what we do is we just educate them that we will be there for them, regardless of how long this takes. Typically, in this latent phase, uterine contractions are fairly mild. They start out erratic before they become very regular and strong, so that switch from the erratic to the regular is your marker for when it starts. They usually range somewhere between 5 to 20 minutes apart, so you can see this is a pretty wide range of time. And they last somewhere between 20 and 40 seconds, so that's that duration, start to finish of one contraction, 5 to 20 minutes apart, start of one, start of the next. Make sense? I would love to tell you that there's an easy way to know these numbers, but there's not, and you just have to know them. It wouldn't be out of the realm of board testing for them to give you an example and say, this is what your patient's complaining of, what stage are they in? So, yeah, you have to know those. Typically, in this stage, this is where the majority of cervical effacement occurs, so that's thinning, because it's much easier for something to dilate if it's a thinner material than if it's a nice big thick material. Cervical dilation typically increases to about 3 centimeters, and usually women come in and they're super excited because, or they're at home and they know that this is the start of it, and they get excited and labor has started and they're all gung-ho about it because the contractions aren't really that bad. They tend to be anxious about the birthing process. They've got a little bit of fear for what's to come. But the pain of the contractions typically can be controlled through relaxation, breathing techniques. Some women will sleep through this stage. They rest. It's not something that is unbearable. They do not belong in the hospital during this stage, unless we have one situation in a normal pregnancy where they would be in the hospital in this situation. What would that be? Their water broke, because they don't belong at home then, because the risk of infection is that much higher, unless they're looking for a home birth. Then we're kind of talking about a different scenario. For the majority of us, we're going to be talking primarily about the hospital setting. After the latent phase, we now progress to what's called the active phase. The active phase of labor, for people that haven't delivered before, typically takes about 5 hours, but again, these numbers are based off of your texts. They vary, your boards. This is not real life. I mean, these numbers really mean nothing to somebody who's actually laboring. There's nothing that says that somebody who's in the active phase for 15 hours is in any worse of a situation. It doesn't compromise the baby. It's not something that we need to intervene on necessarily. This is where we see the most rapid cervical dilation. So typically, this is where we see them start at somewhere around 3 to 4 centimeters, and they dilate to about 8 centimeters. Usually we see much more frequent contractions at this point. They're longer in duration, and they start to ramp up in their intensity. Because what happens is those contractions are basically putting pressure on baby, pushing that baby into the pelvic cavity, onto the cervix. It's that fetal pressure on the cervix that's causing the effacement and the dilation. Because that baby's basically barreling its way out. It's causing that cervix to dilate and make way. So if you are having somebody that isn't having effective contractions, you're not going to see cervical dilation. Probably more information than you guys ever wanted to know, but I'll give you an example. My daughter has a huge head, shaped after her father. It's gigantic. It measured 2 weeks ahead of her body most of my pregnancy. When I went into labor, I got to the active phase. We got to this point. She was engaged. It was going great. And I sat there for 14 hours. And she went nowhere. Contractions were effective. Everything was going smoothly. My water broke. She was engaged. She was doing everything she was supposed to. And eventually they ended up C-sectioning her. When she came out, she had a spot on her head about 4 centimeters in diameter that was a little swollen, because that was the only part of her head that was coming into contact with my cervix, which was not doing enough to cause it to dilate because it wasn't enough pressure. So you could visibly see why she was not coming out, and she just wasn't going. It was never going to happen. So there's a lot of different things that go into making sure all of this progresses appropriately and that it actually happens. You know, we look at hundreds of years ago, when we talked about mortality rates, I would have been one of them. She never would have come out, and I probably would have died in childbirth because her head was too big and I was too small. Like, it just physically would not have happened. But because we have the ability to do C-sections, those kind of kids are able to be born. So I never left this active phase. Cervical dilation typically goes somewhere between 1 to 1.5 centimeters per hour. Lower for people that haven't had kids before, it's higher for people that have, because once the body's gone through it, it sort of knows what to do. And so it goes through the process a lot more smoothly. Fetal descent is progressing, so again, it's coming down into that pelvic cavity, putting pressure on the cervix. And the patient is officially in labor. This is usually where you see them starting to be in the hospital. They are very focused on labor. They tend to request, this is a lot of times where people start to request epidural, because contractions are starting to be really uncomfortable. They can't get comfortable in bed, they're achy, they're repositioning, they're walking, they're trying to do whatever they can to get themselves into a spot where they're comfortable, and they can't find one, because those contractions are starting to get so strong that they're not really able to hold a conversation. They're doubled over in pain. They'll be walking in the hallway and all of a sudden you see them do this on the side because the contraction's so strong. And once it passes, they're fine. But until that contraction passes, they're useless to everybody. This is not really the opportune time to be educating people. So when do we educate people about all of this? Ideally, before they're in labor. When do you think the majority of education happens? At this point. Not ideal. Not what you want to see. Because what you're saying is going in one ear and out the other. The active phase now leads to the transition phase, and this is the most intense phase of labor overall. This goes from 8 centimeters to 10 centimeters of dilation, and typically the contractions are 2 to 3 minutes apart, and they're lasting somewhere between 60 and 90 seconds. Are you noticing the times on those and how similar they are to where our danger zone is? There's not much of a deviation, so it really does behoove us to make sure we're counting things appropriately. The characteristics we see in this transition phase are going to be painful contractions. The cervix becomes 100% effaced. They're getting to feeling like they need to poop. If you have a patient that is in labor, and you see them down the hallway, and you're like, what are you doing? And they're like, I just gotta go poop. I'll be right back. And you're like, no, you're having a baby. Like, get back in that bed because you're ready to push. If you have a patient that says they're going to poop, odds are that baby's imminent. We have delivered babies in the toilet up in the OB floor because they had family members in the room who were trying to be really helpful, and they're like, well, she just had to go to the bathroom, and it's like, oh my God, why? This is why we tell you to call us. Like, I would love to say that we've never delivered a baby in a toilet in the hospital setting where you would think everything should be controlled, but it's amazing how little people listen. Or I shouldn't say listen, but hear you. Because again, when are we educating our patients? It's not entirely their fault. Typically they have trouble concentrating and coping because this is the point of no return. Oftentimes for people that haven't gotten epidural, this is the point in time where they'll see this, I want to go natural, I want to do this without meds, and then they get to this point, they're like, I want an epidural, and you're like, you can't. We're past that window. So once they're in the transition phase, things are going to happen. Nausea and vomiting are pretty common. Part of it has to do with adrenaline and nerves and anxiety. Part of it has to do with the fact that the uterine cavity, the abdominal wall, is contracting down so hard. What else is also in that cavity? Their stomach. So if somebody came over and squeezed your stomach, what do you think you're going to do? You're going to puke. Again, the timing can vary pretty drastically, and really the big take home for that is that people that have had kids before tend to go faster overall through this process than people that haven't. I mean, that's kind of your big consensus as far as that timeline goes. And then unexpected problems throughout any of this may lead to a C-section. I mean, that's kind of just a general statement more than anything. So, do you have a question, Isaiah?
So do you tell them then, because I know, like you said, the educating part, would it be when they're coming in and they're spreading their berries out, kind of the like contractions or hook them up, would that be a time to say, if you at any point feel this need to poop, call them?
Absolutely. That would be a great time to educate them about that. Because people don't like to talk about it. case you've been unaware. Yeah.
Okay, so I was so scared of doing it while in birth because I heard people did it that I, like, when I first went into labor, I sat on the toilet for like an hour making sure that I ended up having a C-section too for the exact same reason, but like, yeah, I didn't want to poop on the table.
Yeah. That's a big education piece actually as well, that it's normal. Most people poop when they're delivering a baby, which when you think about it, like, pardon my French, but life's shitty enough, it's kind of a crappy way to enter the world, but that's sort of the way of it. Most labor nurses are pretty spectacular about being super discreet about it, and it's here and gone before anybody ever knows it's happened. It's pretty impressive at how well they are able to disguise what they're doing. But they do. They'll go to do a vaginal check or whatever it may be, and just like, whoop, and it's gone. And you're like, ha. It's pretty impressive when you get to see them in action. So, any questions on the first stage? So we get to feeling the poop. They're super anxious. They're uncomfortable and in pain. Contractions are really strong. We're fully effaced and dilated. We're ready to go. We hit the second stage. The second stage is called the stage of expulsion. This is where the baby's delivered. Not at the end, not at stage 4. It's stage 2. It starts when that cervix is 10 centimeters, and it ends with the birth of the baby. This is where they get that urge to bear down. A big education piece, and this has kind of been within the last probably 5 or 10 years that we've really emphasized this. We want to make sure that we educate them on proper pushing. We talked about this, I want to say last week, maybe the week before, about not doing this because it doesn't do anything. We have to coach them instead to push like they're trying to poop. There's a lot of pooping talk when it comes to this. And it works. A lot of times you'll hear nurses will say, you know, push through your bottom. Push with the emphasis on your bottom. Because a lot of people try to push through their vagina, but there's not much muscular control in that region when you think about it in the actual anatomy and physiology. People, when they're told to push through their bottom, to push like they're having a bowel movement, will effectively push a baby out. It can last for a couple of minutes. It can last up to two and some hours, where the baby's actually crowning, where mom is actively pushing. We do see an increase in bloody show, so it's normal for there to be blood through this process. If they need to, this would be the stage where they do an episiotomy, which is where they snip basically down that perineal wall. And they used to do it to prevent moms from lacerating, from tearing, or to shorten the second stage. If you've got a mom who's been pushing for 2.5 hours, it may be that that's just a really big baby, and it's not going to come out without further assistance. Episiotomies are not routine. They're not supposed to be done just for convenience, and we don't do them much as often as we used to, because what they found is that tissue actually heals better when it's torn. If you think about when people are building muscle, what we're creating is micro tears in that muscle cellular structure, and the body knows how to heal that. So it actually heals better from a tear that's been sewn back together again than it does a clean cut line. The other component to that is if you have a patient that has a tear or an episiotomy, I can't stress enough how much it is excruciatingly important for us to push stool softeners on them after delivery, because inevitably the number one thing people are afraid of after delivering is pooping. They're afraid of pooping before, they're afraid of pooping during, and they're afraid of pooping after, because they just tore everything down there. They're afraid of tearing stitches. They're afraid it's going to hurt. They're afraid. And what happens when people are afraid of pooping? They get constipated because they don't poop. Well, how much worse is it to pass a stool that's hard, that's been in there for 4 days because they've been afraid of pooping? And oh, by the way, we gave them narcotics, which slowed everything down. The last thing you want to see is a gal that ended up with a third-degree laceration that ends up with poor Howie as an ER nurse in Shoto that's impacted, and he's got to go in and do a manual disinfection because nobody explained to her that she needed to take her stool softeners regularly. I'm sure that would be your ideal patient, right? Yeah. So stool softeners are a huge nursing intervention, postpartum. So that's the end of the second stage, baby's delivered. We'll talk way more about that after, when we get some newborn stuff next week.
When it says can take 2 hours, I thought birth defects happened if it took more than.
It depends a ton on how baby's doing. Some babies tolerate being down there far more than others. There's a lot of factors that go into it. But theoretically, baby's still getting blood and oxygen, still connected to the cord. There shouldn't be any reason that baby can't tolerate that unless baby's tired. You know, if this has been a 48-hour-long delivery, by that point everybody's tired. You know, baby may be compromised, and it may need to happen faster. But no, I mean, I've been to plenty of deliveries that mom pushed for 2+ hours, and you feel bad for everybody in that room, but baby comes out and does fine. It just sort of depends.
So when you hear like things like the umbilical cord wrapped around the neck or something during this, is that from them rotating in there and like moving around?
It can.
Or is it from like you were talking earlier how it falls out first?
It's probably not due to a prolapsed cord, but that umbilical cord's up to 2 to 3 feet long in there. So there's a lot of cord available for that baby to play with. Some babies will wrap the cord around themselves, around their body, around their feet, around their arms, around their neck, just being active during the course of the pregnancy. Some, it'll happen as they get engaged. It may be that there's a loop that they just happen to fall into, kind of like a noose. It will have happened before they entered the birth canal. Because once they're in the birth canal, that head should be the only thing that's fitting, basically. It kind of fills the void. That being said, when we look at preemies or really small babies, that kind of deviates a little bit because of the size.
Would you still continue with the vaginal birth, or would you go back to emergency?
It depends. Some babies, typically that's something you would see on that fetal heart rate. You know, if they're having significant decelerations where they're dropping their heart rate and not recovering very well, it may be that they have to go back for emergency C-section. It just kind of depends. I've been to plenty of deliveries where the cord's wrapped around their neck and they get the head out, and they'll unwrap the cord, and that's one of the assessment pieces that we'll talk about, that on delivery of the head, your first assessment is if the cord's around the neck. That should be your first thing that you look at when that head's out. The third stage is where the placenta is delivered. It starts when baby is born. It ends when the placenta comes out. It can take up to 30 minutes, but usually it's within 5 to 10. Sometimes they will administer oxytocin afterwards. Oxytocin is a derivative form of what our bodies produce naturally, which is Pitocin. Pitocin is what causes those uterine contractions to happen, and oxytocin is what we give them to mimic that. So they may need to give oxytocin in order to promote uterine contractions. When those contractions occur, what's happening is it's actually clamping down on the arterioles in the lining of that endometrium, and it's preventing excessive blood loss. It's helping the site where that placenta pulled away to clot and heal and stop bleeding. The fetal side of a placenta is typically shiny, kind of grayish in color, and then the maternal side looks pretty beefy red, more like internal organs, basically, like what you would think. And if you think about it, that's the side that's getting ripped from mom. It's going to look like that. It's going to look raw and angry. The fourth stage is the stage of recovery. So we've delivered the baby, we've delivered the placenta, and now we need to monitor mom very closely for the next usually 1 to 4 hours until her vital signs stabilize. Blood loss throughout the process can usually vary somewhere between 250 and 500 mils. That's for a vaginal delivery. For a C-section, it can end up being 500 to 1,000, and that's considered normal. As a result, minor drops in blood pressure and a slight tachycardia postpartum in that 1 to 4 hour period of time are considered normal. Okay? Typically, at this point, the uterus should be fairly round. It should be a palpable mass, and it should be somewhere around the level of the umbilicus. If it's high, it's concerning. If it's off of midline, it's concerning. And we'll talk about that here in a little bit and the things that we would look for. In that first hour after delivery, the number one thing that we're concerned about is hemorrhage. So bleeding and firmness of that contracting uterus. We want to make sure it's a nice firm ball. It really does feel kind of like a fist almost in there, like a tumor. You can feel a nice clear edge of where that fundus is to let you know that the uterus is nice and contracted down. So, settings for childbirth, we did talk a lot about these already as far as the home birth, a birthing center, the hospital itself. So, your book goes into disadvantages, advantages. Again, use that as a review. We have talked about that, I would say, a fair amount in the last 2 weeks or so, and it's something I think that's fairly clear-cut. Would you guys agree? Patient teaching guidelines. When to go to the hospital or birthing center. When do we tell them to come to the hospital or birthing center? There's water breaks or
Regular contractions.
that are less than 5 minutes apart, typically. That don't ease with walking, sleep, rest, water, those kind of things. And that's what's up on the top of the screen. So the contractions, that pattern of increasing frequency, duration, and intensity. For the first child, typically we have them wait until they're about 5 minutes apart. For the second, it's when they're more like 10 minutes apart for an hour consistently, because we know that once they get to that active phase, they're going to progress quite a bit faster than somebody who hasn't had a child yet. So ruptured membranes, if they're having any kind of bleeding. Bleeding is abnormal. We want to make sure that they are seen if that's what they're experiencing. However, when we're talking about bleeding, it's bleeding. It's not that bloody show. It shouldn't be pink. It's bright red. Any kind of a decrease in fetal movement, because that tells us that maybe baby's not doing okay. And that goes back to that kick counter we talked about last week. And then any other concerns, if they're not feeling great. We have families come in, and it turns out mom's got the flu and needs to be hydrated, and they end up on the med-surg floor. But important for them to be seen. So, on admission to the hospital or the birthing center, we want to make sure these are basically our tasks. We are doing paperwork, we're making sure we've got their medical information, payment information, having them sign consent. Because once they get to the point where they're in the active and second stages of labor, things like that, they're not going to be able to sit there and sign paperwork for you. They're not going to be able to agree to consent because they're not going to focus.
I think we could have patients. And I was a physician.
So you're technically, yes, wording-wise, you are completely correct. We are not the ones that we don't provide them with the information that they actually sign on. We are there to witness the signed consent. That we can do. You can be the signature that says, yes, I watched that physician provide them consent. Good. That's actually a really good clarification. Collecting admission data, we're doing a complete maternal assessment, so that involves that cervical exam, assessing amniotic membranes, and completing lab tests. When we look at that cervical exam, there's one instance where we absolutely do not do a cervical exam. Bleeding. Because if it's bleeding and we do a cervical exam, there's a good chance we're going to make it worse. Additional assessment data, if they have a birth plan, who their support person is going to be, because there's not necessarily always a dad involved. Or even if there is a dad, maybe grandma's the one that they want as a support person. Again, kind of boils down to that cultural setting. Whether or not they have participated in childbirth classes, we're basically gauging how prepared they are for this whole process. Completing a fetal assessment, Leopold's maneuvers, that's where we can manually palpate to figure out the position of baby. Because if we have a baby that's breech, we're gonna set up for a whole different type of delivery, right? Can breech babies be delivered via vaginal delivery? Sometimes. Per your board, right now, no. A breech presentation is a guaranteed C-section. I will tell you, they used to do a breech, then they went to C-sections only, and now it's starting to kind of come full circle again, and we're starting to see breech deliveries. That being said, if you have a baby that's crowning and it's their butt and it's happening, that kid's getting delivered breech vaginally. I mean, you're not going to shove that kid all the way back up inside to pull them out the other way. That's going to be a little bit more traumatic. I've seen that in other instances, but you don't need to do that for a baby that's tolerating it okay. I mean, the big concern with breech deliveries is an internal decapitation, because what happens is after the head gets expelled from the uterine cavity, the uterus says, okay, the biggest, hardest part is out, and what it does is it contracts down to try to shoot out the rest. if the butt is the part that's come out and the uterus contracts down and it happens to catch right on the baby's neck, now the head's trapped inside the uterus, the body's out. So that's the reason they went to C-sections for breech deliveries, although, like I said, you're starting to see it kind of surface again. So that's really your big concern. We're going to get a baseline fetal heart rate, and then reporting any abnormalities. We are going to complete procedures like putting IVs in, things like that, drawing labs, data collection. It's going to be a focused assessment, so we're going to look on mom's condition and baby's condition, how imminently delivery is happening, because if you have somebody that's getting pushed up from the ER that's sitting kind of sideways, you're not going to get all this done because that baby's crowning. Like, there's a reason she's sitting sideways, and it's because there's a baby right there. she can't sit flat. So again, it's going to be altered a little bit based on the imminence of the delivery. We're going to report elevated blood pressures because that is a sign for our hypertensive state. A fetal heart rate less than 110, that's your cutoff for like fetal intolerance. That would tell you if baby's heart rate is less than 110, baby's not getting enough oxygen, not getting enough blood supply. Or a fetal heart rate over 160. Because what that tells us is that baby's not tolerating labor, they're tachycardic, mom might have a fever, baby might be septic, there's probably something going on. Babies don't just sit with a heart rate of over 160 for prolonged periods of time at the point where they're ready to deliver. Did you have a question?
No, you answered.
Okay. We'll check mom's vital signs, evaluate her contractions, do a cervical exam, again, like we said, if appropriate. Amniotic fluid, so again, that nitrazine test, if we need to, and then evaluating where in the stage of labor we are. Does that all make sense on kind of what we do when they first walk in the doors? Interventions, and this kind of goes back to a lot of the stuff we were just talking about. In that first stage, we're admitting the patient, talking to them, developing a sense of trust. Important to keep their bladder empty. That's a big intervention for us because a full bladder, when you think about it where it is, you've got this nice big uterus, right, with the baby sitting in there. If you have a big full bladder, what do you think that's going to do to the progress of labor? It slows down. Because that baby's not going to be able, the bladder's only going to go so far. If it's nice and full, that baby's not going to be able to come down. So keeping that bladder empty. Placing an IV. And keeping the bladder empty does not mean that we have to put a Foley in. It just may mean that you're in there every 15 minutes, seeing if mom's got to get up and go to the bathroom. IV placement. Monitoring contractions and fetal heart rate. Looking at her effacement, dilation, and station. And then encouraging the dad in comfort measures. And that may be an education piece. If you have a baby that's OP, one of the things the dad can do is sacral pressure or sacral massage. So putting pressure on mom's sacrum to kind of push that occiput off of that vertebral column internally to help relieve some of that discomfort for mom. The second stage, removing monitoring equipment, because at this point, for the most part, you're not going to hear much anyway because baby's so locked down in that pelvic cavity, you're not going to get an accurate assessment of fetal heart rate. Although we would like to continue monitoring it if we can keep baby on it, because if you've got a mom who's pushing for 2.5 hours, the only way we know the baby's okay is that fetal heart rate. Checking that blood pressure every 15 minutes for mom, because she might end up in a hypertensive state, in which case she might need medications like magnesium, or she might need an emergency C-section if it's getting severe enough. Might need fluid, she might need pain meds. Blood pressure tells you a lot during the actual laboring process. We want to educate them to push with the contractions. A lot of times you'll see women that are just super overzealous and they just want to push and get this baby out, and they're just pushing and pushing and pushing and pushing, and their body's not contracting. She's wasting energy because she's not going to push any more effectively than her entire abdominal cavity compressing down on itself to get that baby out. We want her to use her energy and push with that contraction. Make it effective. Once the baby's delivered, we want to establish the infant airway, and then we want to place erythromycin in baby's eyes. Why do we give erythromycin to baby's eyes? There you go. The other thing with the contractions, and this one's been a big one, is to make sure that mom is pushing when she feels the need. Back probably 20, 30 years ago, not even that long ago, 15 years ago, you'd hear people coaching patients. Push, 1, 2, 3, and they're counting through the whole process, right? Studies have found that people are actually much more effective at pushing when they push when they feel like they need to. Sometimes we need to stop the epidural in order to make sure they can feel enough. to be able to know when to push, but we don't know that if all we're doing is yelling at them when to push. Does that kind of make sense? During the third stage, we're collecting cord blood if need be. That'll tell us a little bit more about how baby tolerated labor. Noting what time the placenta is delivered, observing the placenta in its entirety to make sure that it's whole and that there's no pieces or parts remaining inside of mom's uterine cavity that would cause her to continue to bleed. Oxytocin, again, like we said, to increase those contractions if need be. Checking her blood pressure every 15 minutes. Checking that fundus for firmness. Putting perineal pads underneath her is going to be important because that's how we evaluate how much blood out she's having. And then putting warm blankets. It's very normal for postpartum women to get like the chills, like their whole body is just tremoring, and they're not actually physiologically cold. It has to do with the hormonal swing, adrenaline, things like that cause those. It's the catecholamine release that's causing the shivers. Giving them warm blankets will make them feel better anyway, even if they're not cold. As far as bleeding goes, we'll talk a little bit more about it, but it's important to note that having them saturate more than 1 to 2 pads an hour is an extensive amount of bleeding. Usually a full saturated pad is about 150 mils of blood. So if they're saturating more than that in an hour's time, that's a lot of blood loss. In the fourth stage, again, this is that critical hour after delivery. The big concern is going to be a hemorrhage. We're checking that fundus every 5 minutes. We're doing blood pressures and vital signs every 10 to 15. And we're encouraging them to void because, again, if they end up with a full bladder, what that does is it displaces the uterus, and it makes it a lot harder for it to contract down. That uterus is nice and centered, the muscles work effectively, and it contracts down really well. If that uterus is now offset like this, and the abdominal muscles try to contract, do you think it's going to contract as effectively trying to contract this way versus like this? Right, and so it makes it a lot harder for it to contract down, bleeding increases, and now we're back at the risk for a hemorrhage again. So making sure that their bladder is empty is a huge postpartum assessment component. Any questions? Okay. Pharmacologic pain management. There are several limitations that we have during the course of labor. Any kind of pain management is going to put a higher risk for hypoxia because the enlarged uterus puts pressure on that diaphragm. So things like narcotics, like morphine, that we normally would look for respiratory depression in a regular adult, OB patients are at a much higher risk for experiencing that setting or that side effect because of the fact that they're already not breathing overly effectively. They are at an increased risk for aspiration from vomiting, because if you think about where, again, all of that pressure is, everything is now displaced, and they're at a much higher risk for aspirating. Lastly, certain medications cross the placenta. Certain medications will have an impact on the fetus. Things like narcotics will also cause babies to have respiratory depression if they're delivered really close to delivery. One of the things that we can do to minimize that is to try to give it during a contraction, because during a contraction, mom's body's clamped down on that placenta. They're not getting a whole lot of blood and oxygen to baby. That drug is not crossing as effectively to baby. Baby will still get some of it, but it's a lessened effect. Does that kind of make sense on our timing of it, if we can? We want to evaluate whether or not mom has had previous back surgeries, infections, where any kind of an injection might take place, if she's got any kind of blood pressure anomalies, hypertensive states, those sort of things, because that will alter whether or not we can do an epidural or whether or not we alter the medication that goes inside of an epidural. We want to make sure we're keeping the side rails up, having Narcan on hand, because that's what we give to counteract things like morphine or any other narcotics. Before we administer any kind of pain med, we want to make sure we're doing vital signs on mom. We're looking at that fetal heart rate again, because that tells us how baby's responding, any known allergies, and any kind of last oral intake. So how long it's been since she's eaten or had anything to drink, because that also tells us a little bit more about her increased risk for aspiration. Labor can be slowed if it's given too early in the process. They try to hold off giving the epidural until they're well into that active phase, because if not, it can slow down the whole process, because part of how everything progresses is the strength of those contractions. Mom bearing down, mom knowing when to bear down, things like that. Analgesia is what we use to reduce the perception of pain in labor. Important to educate families and patients that it is designed to reduce the perception of pain, not eliminate the perception of pain. There are a lot of people that get epidurals and they're like, I can still feel the contractions, it hurts. Like, well, they're going to. Like, that's never going to go away completely. You just want it to be comfortable enough that they can get through the process. They do reduce gastric emptying. Injections should be given at the start of the contraction, like we talked about. Demerol is a big one we use, fentanyl, Stadol, and Nubain. Those four are all very common narcotics that we use for analgesia. And Narcan is what we use to counter it if we need to. They can cause drowsiness and dizziness, just like they can in your regular adult population. And then the other thing that we can do is anesthesia, which is partial or complete loss of sensation with or without a loss of consciousness. Some moms in truly emergent C-sections we will completely knock out. Regional blocks and general anesthesia are kind of your two big ones on that. Regional blocks can be really nice. Like sometimes they'll do what's called a pudendal block, where they numb the actual pudendal nerve, and so women don't lose motor function, they don't lose bladder function, they don't lose the ability to sense contractions, but they do lose the complete sensation of pain through the pushing process because the entire vaginal area is numb. They're a little harder to place because it means that they've got to be able to localize the pudendal nerve blind, basically just off of landmarks. So you've got to have a really good anesthesiologist to do it. It's a big needle. Kind of scares people sometimes. And when they're told that the pain of the contractions won't go away, not everybody likes that idea. But ideally, yeah, I mean, that's the least side effect driven method that we have for baby and mom. Regional anesthesia, again, there's that pudendal block. It is injected transvaginally. There's an epidural, which is where they inject the anesthetic directly into the epidural space, which is located inside the vertebral column. So basically they have mom sit forward and kind of curve around a pillow usually to open up the spaces between that vertebral column. Again, you need a good anesthesiologist to get it in effectively. And when you think about pregnancy, one of the biggest changes that we talked about in the skeletal system is what when we talk about the spine? The ligaments soften, and they get what's called that lordosis. You remember that lower curvature? Well, where they're trying to put that epidural is directly into that lower curvature, where everything is now compressed and swollen and irritated. So it's a lot harder, and the epidural itself can be pretty painful, depending on how irritated their lower back is. Putting it in. Once it's in, it's fine, but getting it there. The spinal subarachnoid block is something that they usually give for C-sections. The hard part about that is it does puncture through the spinal, the dura, and so they can end up with a spinal headache because CSF fluid has the opportunity to leak out through that puncture site. Spinal headaches suck. There's not much they can do for them short of bed rest. Ibuprofen sometimes for the pain. They'll use IV caffeine a little bit to try to help heal the site and to minimize ICP. And then ultimately, if that doesn't resolve that spinal headache, they'll do a blood patch where they actually patch it with a blood component to heal the puncture site. Contraindications for spinal subarachnoid stuff are going to be anybody that has problems with blood clotting, if they have hypovolemia to begin with, because a drop in blood pressure is oftentimes one of the things you see with spinals or epidurals. When that pain med first hits, when that narcotic first hits that spinal fluid, a lot of times it causes a significant hypotension. We had a mom not that long ago who got an epidural and was sitting in bed and went to get up to go to the bathroom and was down on the floor with a blood pressure of 50/30. I mean, like that, because the spinal kicked in and her blood pressure tanked. And those are the kind of patients you lie them down, you push fluid. Sometimes they'll give epinephrine to get their blood pressure up. One of the things that you'll see when it comes to OB patients, things are really good and kind of quiet and really good until they're not. And then it's like a cliff. OB patients that are high risk and critical are pretty scary, but it can be pretty rewarding taking care of them too. So those are kind of your big things for regional anesthesia and pain. Are you guys good on all of that material?
For the epidural, is that the area that we also educate them and tell them see where the
Yeah, usually that's the anesthesiologist doing that because they're the ones getting consent for it. But it's something really good for you guys to know because typically they leave the room and the patient looks at you like a deer in headlights. And you are more than able to give them education. That's completely within your scope, so long as it's not your education that they're signing off on. Does that kind of make sense when it comes to the consent process? Okay. If you guys want to go take like maybe till 20 till, so like a 7-minute break or so, kind of get up and stretch your legs, and then we'll get into the new material. I'm pretty sure this is on a split screen, and that's why we're getting the weird view, and I can't seem to figure out how they did whatever they did. You guys are all so quiet. freezing up here today. It's so nice outside, but it's like an ice cube in this building. Oh. And I tried to turn the thermostat up, and it's locked.
Is that your jacket?
No. I feel like it's here every week, but I wouldn't wear it. I'm fine when I'm talking because I think I'm moving around enough that stay warm, but.
Do you write all of your own questions, or do you like pull from an NCLEX bank?
Most of them actually come from, well, there's a good portion of them, I should say, that are driven from the text, actually.
That like the publisher provides?
For instructors.
Gotcha.
Yep. And then I supplement that with questions that I've used in the past from other NCLEX sources, depending on how much I can find.
What was that?
Oh, that's because I clicked a button I wasn't supposed to. It basically, there's a setting within D2L where you can go in and make, like before somebody can submit the exam, they have to answer every question or something, and you can click which ones they have to answer. And the first time I taught the course, I didn't realize that was like, that it didn't change anything on your guys' end as far as like the submissions and stuff like that go. So I used to sit there and click through every single button and make sure that they all said mandatory, and I think I probably just leaned on something that clicked on 5 or 6 of them. But you shouldn't see that going forward. It was just kind of an oops on my part. But yeah, didn't mean any. I will say I was super happy to see, I think either everybody or close to everybody got the questions on fatal circulation right. Yeah. I have to look. But I remember thinking that enough of it had come through by that point, the people I got right. So I'm like, oh, yeah.
You'd be able to look and see, like, reopen the test.
After we go through a couple of them today, and then after I get the grades posted, I'll open it for like 24 hours or something, and then take it back. Oh, yeah. I should have them up by tonight at some point. Like, at some point after my daughter goes to sleep today, I will go through and get them up and published. And I don't like sitting on it for too long, because I feel like that's not fair to you guys.
Yeah.
Oh, that was so the midterm exam, is that like a cumulative up to that point? Okay. So we'll see some of these other stuff.
Yep. How did you guys feel about the study guide? Did you feel like it was a fairly accurate representation of what was on there? I mean, it doesn't give you specifics on like where to go, but at least topically you have an idea of where to. Well, and it's not anything that you guys have covered before, and it's a lot of material. You know, you think about Med-Surg, and you take an entire semester learning the normal, and then you take an entire semester learning the abnormal, and in here you're supposed to somehow cram that all into one class. And, oh, by the way, learn pediatrics too. I mean, it's a lot, and I think that's one of the reasons why this course is so hard, because there's not much.
Do you have any good like study suggestions or methods?
I mean, my biggest suggestion is truly understand the normal, so that when it comes to something abnormal, you're not sitting there trying to memorize. You're understanding more of what the deviation is and why you're seeing what you're seeing, so that you're not sitting there going, okay, what does slide 72 on day 4 say about this and that kind of stuff.
And that's what I tried to do. Like, I tried to, like, the study guide was like, go through and be like, okay, this is what preeclampsia is. And then I guess I'm having a hard time taking that, because it's not like you're going to ask questions.
Right.
So how do you, like, apply them to
what you're going to, right. And I think case studies are probably something really good for you guys to review. Like, I think if any of you have looked into the case study for this upcoming week, that's due next week, it will help you. I think it'll help you with the questions, because it'll help you figure out how you're seeing what you're seeing and applying it. Because that ultimately is where a lot of these questions are coming from. Like you said, it's not just a, what is this? A, B, C, or D. It's, I'm going to give you a whole bunch of symptoms. Figure out that you know what that means, and then expect you to figure out what the nursing intervention is that comes along with it. Because nobody walks into your ER with a sign that says, I have this. They just don't. And so your boards expect you to be able to kind of figure out a little bit of it. I mean, they're not going to expect you to know the ins and outs and details of every single little thing, but I would say doing a lot of practice questions really helps. Your ATI, even though you only have so many that are required, use them. You're not going to go through all of them by the end of the semester anyway. You're paying for it. You might as well use the resource. You know, I think taking a lot of practice questions will help, because then when you get to content areas that you're like, oh, I didn't know that, at least at that point it'll give you a reason to go back and kind of realize that you need to clarify it before it hits you on an exam.
So the case studies, do you know of any resources where you can find stuff like that? Or?
There should be, I think your text has, if you go on the online. I think it's got a fair amount of practice questions too. If not, I can look and see if I can find a good source if you think that that kind of stuff would help. I think a lot of it is going to boil down to just getting used to the questions and figuring out how then to focus your studying so that it sticks for you. For me, going through this kind of stuff, really my biggest asset was always if I could understand the underlying, then when it came to the questions, I sit there and I talk to myself. I mean, I'm that crazy person that's like mouthing things in the back of the class and everybody's like, oh, what about her? Because I sit there and if I talk myself through it, I'm in a much better position. If I can sit there and I can read the heading and I can say, okay, I mean, basically take these questions and do exactly what you're doing with the ATI with them, break it down and say, okay, this is my patient. Regardless of what the answers say, this is what I'm going to be seeing. If this is what I'm seeing, what would I expect to do? And if when you're going through and you're studying, if you can create that cascade for all of these things, you should be good, because that's what it's going to ask you. What are the symptoms that you're going to see? Why are you going to do the things that you're going to do? And if you can understand it, you're in a much better position than trying to just shovel all of this into your brain and memorize it. Because, I mean, the people that try to memorize this stuff don't pass these exams, because you can't. I mean, there's just so much to cover that if you tried to memorize it all, you wouldn't get anywhere. So that's kind of the direction I would take it. And use the quizzes. I mean, if you're coming out of the quizzes without getting a 5 out of 5, even if you jot yourself down like little notes, like, okay, I know this question was about this and this question was about that, then go back and look through all of it. Kind of like with the ATI, and we're going to talk a little bit about that at the end of class really fast on sort of what my expectations are, more because it will benefit you guys, I think. Are you good if we dive into the new stuff? Okay. I'm hoping that I'll leave us about 15 minutes at the end of class to go through the questions and talk a little bit about the ATI. I'm waiting to find out from my husband whether or not he's picking my daughter up or not, because if he is, then I can probably stay just a tad bit late and go through stuff, which you guys are welcome to stay for or leave. It just would be up to you. But
I just had one question.
Mhm.
Do you know any good ways to narrow down the study guide? I thought like a lot of it was so broad that, you know what I mean?
yeah, the hard part with that is I don't want you guys to go through and cherry pick to be able to take my test. Because ultimately, the goal is that when your boards come, that hopefully you won't have to study this stuff that much. I will tell you, when I make the PowerPoints, I have an NCLEX PN and review book, and I literally sit there with our textbook and this and pick out the stuff that should be pertinent for your boards, and that's what we're covering in class. You'll notice there's a ton of material in your textbook that I don't even mention, and that's why. Because I want you to be able to come out of this having studied really well for here, so that 3 months after you graduate, you're not trying to relearn all of this on your own. So while it would be great if I could taper down the study guide so that you guys could all get hundreds on the exams, short of giving you the questions, that doesn't really do much for you, aside from giving you 100, you know. I can try and be slightly more specific, but kind of like I was saying before, if it comes up to like a patho section where it says this diagnosis, expect that you should know what that diagnosis is, you should know what you're going to see, and what you should be doing for it. I mean, that really should be, if you can do that for everything, you should be able to get through this stuff. Because if you'll notice the questions on the exam, that's what they all were. They all were, what are you going to see, what are you going to do about it? For the most part. I mean, there were a couple in there, you know, like the history of nursing or whatever, that are a little bit more vague, but that's kind of the general premise of all of this stuff. You know, when you're looking at the stages of labor, you should know what you're going to see, what to expect, and what you're going to do. you know, it's going to be kind of the same concept going forward. Okay? So, in this remainder of the class, we're going to talk about some of the complications that we see. Some of these we've touched upon a little bit so far. We're going to recognize our role in assessing, identifying, and treating them. So, exactly what we were just talking about. And then we're going to talk about postpartum changes and how what we're seeing impacts our care. So, infections. There's a bunch of different infections that can cause congenital issues with baby. Congenital meaning they're born with the defect. TORCH is one of the types of tests that we run, and that evaluates the toxoplasmosis status, other infections, nice little vague O there, rubella, CMV, and herpes. CMV is the cytomegalovirus. O for the other infection stands for a whole group of things: syphilis, HIV, HPV, parvovirus, hepatitis C, and group B strep. Group B strep is the only one that's evaluated not by a blood test. All the other ones are a blood test. The group B strep's a clean catch urine specimen. They do after 36 weeks of gestation. Moms that are group B strep positive, when they come in for labor, they will do a series of antibiotic administrations of penicillin G in order to get rid of that group B. Group B strep is something that colonizes the vaginal canal in a lot of people. It doesn't make mom sick. It doesn't do anything to her. However, babies exposed through that group B strep positive canal can end up with a very late onset sepsis, like 2 days to 2 weeks after delivery. And before we started doing this group B strep screening and treatment, kids used to die from it because they got sick so fast. They'd get sick at home, and 18 hours later they'd be dead in the hospital because they get so overwhelmingly sick from it. So that's one of the reasons why we screen everybody. But they wait until 36 weeks because there's no point in treating it beforehand. Like if mom's pregnant at 25 weeks, they find out she's group B strep positive, and they treat her for it, it likely will come back because it's a colonization. It's not an active infection. UTIs can precipitate preterm labor. Oftentimes, if we don't have a cause or a known reason for why mom went into labor, the assumption is that there was some kind of an infection brewing in her system somewhere, because what mom's body does is it says baby's better out than in, and it kicks them out, pretty much. Treated with antibiotics and Tylenol for fever purposes. Tuberculosis is something that we do see. They can be started on the isoniazid during pregnancy for an active infection. The fetus, as a result, is not at risk in utero, and breastfeeding, however, is not recommended because baby could contract it post-delivery. So, tuberculosis is one of the situations we do not recommend breastfeeding, and HIV is the other. We're fine with mom's breastfeeding with just about everything else. With HIV, mom is given antiretrovirals during pregnancy. We encourage her to maintain her vaccinations, and we monitor baby for up to 2 years after delivery for positive or negative status. Baby will also end up on an oral antiretroviral post-delivery, and depending on the dosage, it may be for a couple of weeks or a couple of months. STDs can pass diseases to babies before, during, and after birth. We have talked a bit about those, that chlamydia infection that we give erythromycin for. Complications that we see as a result of STDs are going to be premature birth. LBW is low birth weight. Conjunctivitis, that's the erythema toxicum, or not erythema toxicum, ophthalmia neonatorum that we see, the blindness that can happen as a result. Gonorrhea tends to cause more of a conjunctivitis, whereas chlamydia tends to cause more of the actual infection that can lead to blindness. Pneumonia, we have had kids that end up with like a chlamydial or a gonorrheal pneumonia. Sepsis, blindness, deafness, meningitis. CMV especially is one of the more damaging ones that we see a lot of these kind of bigger ticket items with. Acute hepatitis, we see that a lot with HSV for kids that are delivered through an active lesion. Chronic liver disease as well as cirrhosis. So it's not, STDs are not a benign infection when we talk about how it affects that growing fetus. So education is key, screening is key, and trying to keep people from obtaining them during pregnancy is ideal. Substance abuse is something else that we see, unfortunately, a fair amount, especially in the state of Montana, even during pregnancy. It can cause abortions, preterm births, as well as stillbirths. We probably should add on there that it can cause placental abruptions as well, because we do see that with methamphetamines as well as cocaine. They are at an increased risk because moms typically have poorer nutritional habits. You know, if they're poor socioeconomic status, they don't have a lot of money, and their priority is to get drugs, they're going to do that over buying the high folic acid prenatal vitamins to make sure that their nutritional status is up to snuff. They are also a higher risk for things like poor hygiene, physical, I clearly did not proofread this, I was supposed to say physical, and psychosocial deterioration as well. Their coping skills aren't as well organized, and then we worry about things like cardiomyopathy in a lot of these patients. We had a mom not that long ago who had a 27% ejection fraction when she came in pregnant because she was Hep C positive, she'd been a chronic IV drug user for years and years and years. I mean, she's just done significant damage to her body. Now that body has to somehow cope with being pregnant. You know, it definitely puts the neonate at a much higher risk along the way. The other thing it does is it predisposes these kids to developing withdrawal symptoms after delivery. There's two different kinds that we see. There's a supervised withdrawal where we're basically just monitoring it. They don't necessarily need medication to help them progress through the process. Their scores, their withdrawal scores aren't bad enough to warrant treatment. And then there's substitute therapy, and that's where we basically medicate them with morphine or phenobarbital or clonidine, methadone. It sort of depends on the type of drug and the area and which facility is administering it and what's available to them. But morphine is probably the most universal drug of choice, and what they do is they basically, especially for our like Subutex and Suboxone users, is it basically causes the baby to get addicted to morphine, suppressing the symptoms of the withdrawal as they're coming off of the Subutex or the Suboxone, and then we slowly taper them off of the morphine in controlling their symptoms. Because unfortunately for a lot of these drugs, there's nothing that we can give them to substitute exactly what they're on. We can't go and give a baby Subutex. There are certain drugs, like if they're on narcotics or hydrocodone, we can give them morphine, and what in those situations it actually does is the neurological receptors that the hydrocodone or the Vicodin or whatever it may be are attached to, the morphine will actually kick out and displace, and so we're not necessarily getting them addicted to a different drug, we're just substituting one for the other, and then tapering them off of it the same way. Does that sort of make sense?
In those kinds of situations, is the baby removed from the mother they are?
That is a sticky situation. Unfortunately, we see a ton of it in the NICU. It depends on what part of the state. It depends on the statutes. It depends on whether or not they fall under the category of reservation or not, because they're governed by their own system, their own health system, their own child family services system. The eastern part of the state is much better about it than the western part of the state. We are very much in a lacking situation where we don't have enough foster families for these kids. So unfortunately, a lot of times they end up going back with the families they came from. I would say probably more often than not, until something drastic happens. They started a program up on the eastern part of the state a couple of years ago in response. They had a kid that had gotten removed that I had taken care of, and 2 weeks later got returned to mom and dad, and then mom overdosed and smothered the kid in bed. And so they overhauled the whole system out there and changed it around and made it so that if anybody came in and tested positive at any point during the pregnancy, they automatically incarcerated mom, put her in a withdrawal program. Everything was controlled so that she couldn't be on street drugs, things like that. And then baby was put into a temporary holding situation for 2 weeks until mom could prove that she could take care of the child and stay clean. Sounds great, right? Exactly.
Right.
So now they just come in with no documentation of anything, and they deliver this child, or they try to clean themselves up prior to delivery, because we all talked about the signs and symptoms that you see. Well, what happens when they start to pull back on their substance use? That baby starts to withdraw in utero, and when they deliver 3 days later, that kid comes out seizing because they're so far into the withdrawal process that they're immediately showing symptoms. So it's one of those where there's just not an easy answer, and unfortunately, it makes it very hard not to get jaded taking care of these kinds of families. I could probably talk for hours on this topic because it's hard. It's probably one of the hardest things that I've ever had to do in nursing is discharge a baby back to the family that I know caused all of these symptoms. Knowing that they're growing up in an environment that's not conducive at all. But if you can figure out the end-all answer that fixes it, I encourage you to pursue that because this country needs it, unfortunately. Our drug substance abuse numbers when it comes to even pregnant women has skyrocketed over the last decade. Like, we're not talking about doubled or triple. I mean, it's like tenfold over the last several years even. And what they're saying is that we're just seeing the beginning of the epidemic because now you're thinking about all of these kids that are born into a lifestyle that's not conducive and they're born with addictive personalities because that's what they were exposed to all along. We've kind of created a whole new generation of this. So it's not an easy topic by any means. Multifetal pregnancies. These by nature are going to be higher risk. By definition, it's where there's more than one fetus developing in that uterine cavity at the same time. Monozygotic, we talked about this when we talked about genetics, and I'm pretty sure a good amount of you guys got this question right on the exam. Monozygotic means they're identical because we've got one egg that's split. Dizygotic means they're fraternal, so we've got two eggs from the start, two eggs that get fertilized. They're going to be completely separate individuals. They're potentially going to look very, very different. You might have one that's a brunette, one that's a blonde. You might have a boy. You might have a girl. You might have a black baby and a white baby. It happens fairly often, especially if you've got mixed-race couples. So just to keep that in mind, that should all be a review, but you do have the picture on the right-hand side that walks you through the difference between identical twins and fraternal twins and how that happens. Signs and symptoms of a multifetal pregnancy. If you hear two heartbeats that are fetal heartbeats, what do you have? Two babies. Palpation of multiples of limbs. That's not necessarily diagnostic because you could have abnormalities and deformities, but odds are if there are 4 arms and 4 legs, there are 2 babies in there. If mom has a larger than normal uterus, because if somebody's growing more than one child in there, they're going to get bigger faster. So somebody that's measuring large for gestational age when we're looking at that fundal height measurement. Striae gravidarum are more noticeable earlier in pregnancy, so basically they're getting stretch marks a lot earlier because they're growing a lot faster. And then confirmation is done by ultrasound. So the heartbeats and then the ultrasound are the official diagnostics. The other ones are just signs and symptoms. And then nursing for us, our role really boils down to they're going to have more frequent prenatal visits. We are going to be monitoring them for signs of preeclampsia, those hypertensive states, because for some reason multifetal pregnancies are automatically at a higher risk for that, more so than a regular pregnancy. Preterm labor is much more common because we talked about the things that cause labor, right? It's that pressure on the growing uterus, it's the pressure on that downward force causing the cervix to dilate and efface. When you've got twice the size, twice the volume, twice the baby, putting all of that pressure on there, there's a much higher chance of earlier rupture, earlier labor. And then there's also are at a much higher risk of postpartum hemorrhage and infection. Because you think about the strain and the stress that either one placenta or 2 placentas is now putting on that uterine lining, we now have a much larger surface area that has the potential to bleed. Does that all kind of make sense on why we see that?
Well, when there's 2 babies in there, are there 2 different placentas that they're eating? Just one?
It depends. So with monozygotic twins, where you've got one egg that's been fertilized that splits, it depends on when in the multiplication mitotic stages that split occurs. The later it occurs, the more similarities babies have. So the later it occurs, the more likely they are to have 1 sac, 1 placenta. You could still have identical twins that have 2 placentas, 2 sacs. It just means they split earlier in that division. Fraternal twins always have 2 placentas, 2 sacs, because they're forming as 2 completely separate individuals right from the start. Okay? Yes, absolutely. Fraternal twins are way safer. Monozygotic twins, there's a whole lot of complications that go along with that. They can have things like twin-to-twin transfusions, where basically one twin takes all of the groceries and the other one starves, because and you'll end up with one that has a crit of 80 and one that has a crit of 12. Monozygotic twins, especially if they're mono-mono, which means one placenta, one sac, they have a much higher risk of fetal demise because now you've got two cords in the same space and they're all spinning and jumping and moving around, and they get tangled up in each other's cords or tie knots in each other's cords. Monozygotic twins in general are just a much riskier scenario. Fraternal twins, because they're in their own little world, it's a much safer process, although it's still a higher risk than just having one in there. Does that kind of clarify all that? Okay. Oh. So, preterm labor. By definition, since we just mentioned it, preterm labor means that labor has started somewhere between 20 weeks, because they've got to be viable, and 27 weeks of gestation. It accounts for the most perinatal deaths not resulting from congenital anomalies. So our number one cause of fetal death is going to be congenital anomalies. There's something that has gone awry in the developing process of baby. Next would be preterm labor. Our goal for Healthy People 2020 is for 90% of all pregnant women to have prenatal care starting early on in that first trimester. Because what do we do at that first appointment? What kind of an assessment do we do? A full head-to-toe general assessment, right? Because what does that tell us? Mom's health. What's our number one indicator and predictor of baby's health? Mom's health. If we can get people in, we can identify the high-risk patients. We can identify problems that we need to resolve early. We can get people into treatment programs. We can get them eating healthier. We can do all of these things that prevent things like preterm labor. So ideally, if we can get them in early, we're at least identifying the higher-risk patients that we can now intervene for. Risk factors for preterm labor: if they've gone into preterm labor before, they are at a higher risk of going into preterm labor in the future. Multifetal pregnancies, any kind of an infection. This mentions just bacterial vaginosis, but really any kind of an infection will predispose somebody to preterm labor. A shortened cervix. If we are looking at fetal abnormalities, it's kind of like mom's body sort of knows that there's something not going quite right, and so the risk of going into preterm labor is that much higher because her body tries to induce itself. Hydramnios, the other term you'll hear of that is polyhydramnios, and that basically means that there's an excess volume of fluid. If you put a balloon over a faucet, and you turn that faucet on full force, and you fill that balloon up, and then you keep filling it, there's a good chance that balloon's going to rupture, right? Yeah. Same concept. Exactly. Substance abuse, a lot of that has to do with nutrition, blood pressure shifts, things like that. Poor sociodemographics, they found in general across the board that has a predisposing factor to preterm labor, but there's a lot that goes into it. When you think about prenatal care, availability of prenatal care, getting to those visits, I mean, you think about how many people that are in a poor socioeconomic status, are they going to be able to take off work to go to the only appointment that their OB has at 11 a.m. on a Tuesday? No, especially when they're living paycheck to paycheck. They're going to be at a higher risk for things like preterm labor because they don't have those identifying factors. They don't have the ability to get to the health care that they need. Trauma or surgery during pregnancy, so car accidents, if mom ends up with kidney stones that need to be surgically removed, all of that kind of stuff puts a stressor on mom's body, puts her at risk for going into preterm labor. And then periodontal disease. People with poor dentition, poor dental hygiene, are at a higher risk for going into preterm labor because infections are at a higher risk. There's also associations with poor nutrition, poor absorption, that kind of stuff. So making sure that they're still going to see their dentist even when they're pregnant. Criteria for it being deemed preterm labor is we have to have uterine contractions every 5 to 10 minutes, so they're regular, they're 5 to 10 minutes apart, they're lasting for at least 30 seconds, and we're persisting for more than an hour, which by definition is through labor, right? They also have to have cervical dilation and effacement. part of that first stage, that latent stage of labor, right? In order for it to be deemed preterm labor, they have to be in labor. So that's a big one, because just because they have contractions or just because they have dilation doesn't necessarily mean it's preterm labor. They've got to have both. Symptoms that we see: cramping, nausea and vomiting, because their body's starting to get ready for that laboring process. That's that adrenaline, that catecholamines, that kind of stuff that's causing that release. Vaginal bleeding or changes in discharge, that bloody show. The other reason that we talked about why it's important if people are experiencing any kind of vaginal bleeding that they get seen is because it may be the precursor to preterm labor, or associated with it. Vaginal or pelvic pressure. We've had a lot of patients that have come in and they were like, well, I just thought that I was sort of constipated. I haven't pooped all that regularly. I don't really feel that great. I didn't realize it was that my baby was down there putting all that pressure. Low back or thigh pain, again, when we were talking about where that baby is once they're engaged, even in premature states, even at 24 weeks, that can put enough pressure down on that groin area to alter the blood flow to the legs. And then oftentimes, PROM, which is premature rupture of membranes, oftentimes that will actually precede the labor itself. Sometimes what we'll see is a mom will come in because she's ruptured at 25 weeks and we stick her on bed rest for as long as we can to keep that baby in until true labor kicks in and we can't stop it. Because the longer baby stays in, they've found that on average, 1 day inside is equivalent to 3 days in a NICU. So we like to keep those people pregnant as long as we possibly can, even if they're ruptured. Oftentimes those moms end up on bed rest and end up on long-term antibiotics to keep them from getting an infection in order to make sure that the number one thing we're worried about with ruptured membranes is infection, right? In order to keep that from happening, they put them on antibiotics. We had a mom not that long ago who ruptured at 22 weeks, and I think she just delivered, and she was, maybe it was 33 weeks, I think, when she finally, she ended up with an endometritis, so she ended up with an infection in the endometrial lining, and baby had to be delivered at that point. So she kept that baby from not being viable. She sat on bed rest, strict bed rest, like bedpan bed rest for 11 weeks. A long time, but she did a great job. I mean, we don't always get that kind of a result, but it's pretty impressive when you do see it. So, management of preterm labor. First thing we're going to do, or not the first thing, but things that we're going to do. We're going to get baseline vital signs on mom. She ends up on continuous fetal monitoring because how do we know baby's doing okay in there? Fetal heart rate. We'll do a fetal biophysical profile, and it's basically where we give a score to the baby based on things like fetal breathing and amniotic fluid volume and fetal movements and that sort of stuff, and it's a score out of 10. And anything greater than 8 means that baby's doing okay. Anything less than 6 means that baby's got to come out because it's starting to be compromised. I don't expect you guys to know how to calculate it, but at least know kind of where your thresholds are. We'll do that nitrazine test to make sure that mom's actually ruptured, and we monitor for chorioamnionitis, which is that infection of the amniotic and chorion. So basically it's an infection within the placenta itself. If mom has ruptured for more than 18 hours, that's kind of our cutoff where we start to really worry about infection. And we assess for a prolapsed cord. So when we manage preterm labor, the very first thing we do is assess for a prolapsed cord by, what do? Checking fetal heart rate. Magnesium sulfate and terbutaline are two of the things that we can give to stop labor because they decrease muscle irritability. They both do that. Terbutaline used to be used as a beta-2 agonist. They used to use it for asthmatics before they realized that it stopped labor. 30-some years ago, my mom was on terbutaline her whole pregnancy and never went into labor with me because they didn't know it stopped labor. They don't give it routinely for asthmatics anymore, but they use it very routinely for preterm labor. Tocolytics are what they give. That's the term that they use for the management of preterm labor, and magnesium sulfate and terbutaline are your two big guns when it comes to tocolytics. However, we have to be very careful in patients that have diabetes because it can cause more of an insulin resistance. It alters that carbohydrate metabolism a little bit. So the other situation that we don't use it, absolutely do not use it in women who are hemorrhaging because what it does is it vasodilates. That terbutaline especially causes a vasodilation effect. So if you've got somebody who's hemorrhaging and you give them something that vasodilates, what have you just done to that hemorrhage? You've made it way worse because you open the floodgates. So if they're hemorrhaging, we do not give it, and if they have any fetal distress, we don't give it either, because if baby's having any kind of distress, that baby needs to come out. We don't have any business stopping the labor at that point. We want to make sure that we're monitoring mom for tachycardia or low blood pressure, because those are side effects of both magnesium and terbutaline, because again, we get that vasodilation, hypotension, mom gets tachycardic. And we want to make sure that if those kind of situations are happening, that we put her in a Fowler's position and we give her oxygen. Oxygen's really a pretty safe bet with almost anything when it comes to OB stuff. If she's having any kind of chest pain or shortness of breath, we absolutely need to stop it. Table 11.1, I'm wondering if that should still be accurate, I think, for you guys. I have to go look. It just has a list of the tocolytic drugs that you may see as far as the names go. These are the universal side effects, symptoms, things that you need to monitor for. However, you do need to know what the drugs are. You need to be able to recognize it as a tocolytic. I don't expect you to know the ins and outs of every single little one. Understand the generalized stuff that you're looking for. We'll give mom steroids. Steroids for mom actually put her system into a stress state. That tells baby that things are imminently changing, and it actually causes baby's lungs to mature faster. So we give mom steroids. We put her on immediate bed rest. We want to make sure she's adequately hydrated, because when they're dehydrated, it actually causes that posterior pituitary to secrete oxytocin. Well, what does oxytocin do? Causes uterine contractions. So if we can stop that process by making sure mom is hydrated, the oxytocin goes away, uterine contractions go away. It's one of the reasons we see preterm labor so significantly in the summer. During parades, all that kind of stuff, we see a ton of moms that come in preterm labor because they've been out and in the sun and not paying attention and they don't drink enough. They come in preterm labor, you want to make sure they're hydrated. That's a really good one, especially for you guys that are going to be practicing in the outlying region, because if you can stop somebody that's in preterm labor, you can save them a Mercy flight trip down here just to get IV fluids. That's a big one. Preventing infection, because if they have ruptured, obviously we want to make sure that we're getting antibiotics on board, keeping that mom and baby safe. So box 11.1 goes through basically a review of all of this kind of stuff for you guys in more detail. I would encourage you to review that, especially, so that you really are aware of our role when it comes to preterm labor. So dystocia. Dystocia we talked a little bit about when we were looking at that fetal descent and the passage and how the baby comes out. Dystocia by definition is a dysfunction or abnormal labor. Pretty vague. Things are not going the way they should be going. We suspect dystocia when mom's cervix is not dilating as we would expect it to, or the fetus isn't descending as we would expect it to. The other situation that you'll see that in is if uterine contractions are not effective. Babies that are OP, we see that a fair amount with. They actually have a pattern of contractions that are pretty typical, and it's called coupling. And so you'll see 2 contractions together and then a pause, and then 2 contractions together and then a pause. And for some reason, the uterus is it's struggling to get that baby to progress, and so the actual contraction pattern is now dysfunctional and not effective. Uterine dysfunction or abnormalities, pelvic size and shape, fetal abnormality, if baby's huge, if there's a malpresentation, so if you have a shoulder presentation, or baby's OP, malpositioning, if mom is super anxious or really tired. These are all things that can cause dystocia. Dystonic contractions, kind of like what I was talking about, that coupling effect, they are still painful, but unfortunately now they're no longer effective and they're asymmetrical. So you're getting these contractions that are not following a normal pattern. One of the things that you might see with babies that are having this dystocia situation, if it has to do with fetal positioning, one of the things they can do is try to change the fetal position. They don't try until after 37 weeks. These things terrify me. I've seen one go wrong in my life, and that was enough for me to be scarred forever. There are technically three major complications that can go along with an external version. And basically what they do with an external version is the OB will typically medicate mom a little bit with some kind of a pain medication to relax her abdominal wall. She'll take a hand on one side of the baby on the butt and one on the head and literally forcibly turn that baby from the outside. Oftentimes they'll have mom on all fours to try to aid the process, but I've had several patients tell me that the external version is more painful than the actual labor itself because you're forcibly turning a baby that doesn't want to turn. Contraindications, so the risks that go along with this, if you can imagine it, one is going to be a prolapse cord, because if mom ruptures in this process, that you don't know where that cord is. Two is an abruption, because again, you risk ripping that placenta off of the wall of the uterus. And the third one that I've seen, it was on a mom that had they probably shouldn't have been doing it, but she ended up with a uterine rupture. So her uterus literally ruptured open, and all of those are very clearly emergent C-section situations. External versions should not be performed anywhere that is not prepared to go back and do an emergency C-section. It's one of the prerequisite requirements that you should be assessing to make sure that you have all of that at your disposal if you're going to be assisting or somebody's going to be doing an external version. Box 12.1 goes through some more of the contraindications. Previous C-sections, obviously you can imagine that uterine wall is thinned where that incision was. You don't want to be putting any kind of tension or pressure on it that doesn't need to be. Cephalopelvic disproportion is what that CPD is. So basically cephalo, head, pelvic, pelvis, disproportion. Baby's head's too big. They're not going to come out vaginally anyway. There's no point in putting mom through that process. If she's got a placenta previa, so again, if that placenta is low-lying and there's a good chance she's not going to be able to deliver vaginally, why are we bothering? If we've got a multi-fetal gestation, because there's a lot at risk there. And then any kind of uteroplacental insufficiency, so if mom's blood supply to the uterus isn't adequate to begin with. The other thing that is associated with versions that we don't talk a ton about is the fact that even though they may successfully get baby to go from a breech to a cephalic presentation, babies tend to like to be where they like to be, and oftentimes they flip back anyway. So they may go through all of this and then ultimately still end up with a C-section. So education for you guys to be able to provide to families is going to be important. Like I said, they terrify me, so.
Can she know or not?
Oh, absolutely. An external version is something that requires consent. It's because of all of the risk factors that go along with it. It's not something that physicians just decide to do. Management, obviously we're going to be monitoring the baby, cervical change, any vital signs. Sacral pressure is what I was talking about before for those patients that are OP for pain relief. And one of the things that we can do to help them naturally flip sometimes is we'll put mom on all fours and tell her to swing. And sometimes that swinging motion is enough to get baby to flip on their own. Much more benign process. Granted, that's talking about OP to AP, or OP to, that shouldn't say AP, that should say OA. Getting baby to go from backwards to forwards, basically, not butt to head. But sometimes it will help with the progress of the labor. Prolapse cord, we've talked about this quite a bit today. It's basically when the umbilical cord precedes that fetal presenting part. You can see in the picture, this is a breech baby with a prolapsed cord. Risk factors, so if membranes have ruptured before baby's fully locked in and engaged, if you've got a small fetus, because now proportionally there's a lot more room around that baby for that cord to slip down. Babies that are breech presentation do have a much higher rate of that, because if you think about it, the umbilical cord comes out, it's a much easier place for it to go down below the butt than it is for it to float up above the head. If they're in a transverse position, if they've got the transverse lie going on, polyhydramnios or hydramnios, because they've got a lot of excess fluid, there's more fluid there for that cord to float around in. An unusually long cord, or multi-fetal pregnancies as well. So, when you have a patient that has a prolapsed cord, the only way to resolve that is to get the presenting part up and off the baby. There's a couple of ways that we can do this. Probably the most common way that I've seen is it's happened where patient's in the ER or comes in on OB, and fetal heart rate's low, and they go to assess for a cord. They go to do a vaginal check, they feel a cord, and the only solution at that point is they push. And that arm gets put all the way up there to lift that baby up and off of that cord. And then that nurse stays there until that baby gets delivered via C-section and pulled out the other way. So they get draped sterilely. Yeah, it's impressive. I've been in several deliveries with prolapse cords, and they're all, it's an emergency situation. The other thing that you can do, if you're not somebody that is experienced at doing cervical checks and those sort of things, is you can get mom into a knee-chest position. If you think about it, if she gets her knees up to her chest, she's opening that pelvic cavity up and potentially relieving some of the pressure off of that cord. Get her into a side-lying position, although that's less effective, and then Trendelenburg. That's the other big one. You get mom on her head, there's a good chance baby's going to go with gravity, pull off of that cord, and give it a little bit of relief. The best option is going to be that sterile gloved hand that now pushes the presenting part away from the cord. You want to start mom on oxygen, monitor fetal heart rate. In the midst of all of this, you are calling the provider. However, your priorities are get that baby off, get mom on oxygen, then call. Because if you call for that provider first, that baby may be dead before any other intervention gets done. So you intervene to save baby, then you call for help. And you hope that somebody is close enough down the hallway that they can hear you scream, because you're stuck where you are. It's not like you can go out in the hallway and ask. So typically it's a rapid C-section or vaginal birth. If that baby is close enough to delivery, or if you have, like we've had it where it was a 24-weeker with a prolapsed cord, mom doesn't have to be fully dilated. If that baby is presenting with the cord and they're right side by side, you can get a rapid vaginal delivery out of that, rather than taking the time to rush baby back to the OR. But typically it's a C-section. These are the pictures. You've got mom in that knee chest. They show it so nicely with just like two little fingers looking like you're not arm deep in the picture, but every time I've seen it, they're literally, full gloved on hand all the way up, putting pressure to get that baby off. And then the bottom picture is Trendelenburg with mom's head down. Oftentimes we'll have mom on her back in Trendelenburg also. But those kind of give you the visual to show you how we're getting baby off of the cord. Uterine rupture, this is what I was talking about before. It is rare. I've only seen 2 in the almost 10 years I've been doing this. But it does represent an absolute emergency condition. You have to deliver these patients via C-section. There's no other option because that baby is now floating around in the abdominal cavity. We end up with severe maternal bleeding and shock. VBAC, so a vaginal birth after a C-section, that's one of the potential complications of it. So when patients come in for a VBAC, that is also something that warrants significant consent from the physician because it is a risk factor that is associated with. Cephalopelvic disproportion, although I haven't really seen that without other complications. And then poorly monitored use of oxytocin. So when we talked about having those contractions that are too close together, one of the reasons that we will see that is because of this poorly monitored use of oxytocin. So oxytocin is administered in too high of a quantity. Those contractions will continue to speed up and get closer and closer and stronger and stronger. If we don't titrate that back down, uterine rupture is one of the things that we worry about because you're stressing those uterine muscles. Not something that I would expect you guys to know like the ins and outs of, but at least know that it is something that's a potential condition complication that we watch for. And then forceps deliveries. There's a picture of forceps here in just a little bit, and it's basically a shoehorn that when mom is having trouble or is having ineffective pushing or you've got a baby that's stuck, they will literally grab that kid's head with these forceps and shoehorn them out of mom's vaginal canal. You can imagine that shearing force is enough potentially to cause that uterus to rupture as well. The only 2 that I've seen, one was a external version and one was a VBAC. Impending rupture symptoms, really what we're looking for at that point are going to be those uterine contractions that are lasting more than 90 seconds. Emergent uterine surgery, there's both the situations that I saw, they ended up with hysterectomies and one of the moms died. It's not something that we handle lightly by any means. Without immediate treatment, maternal hemorrhages, fetal death are likely complications, and when they say likely, it's even with immediate treatment. Those are fairly high risk. Scary stuff. When we look at inducing labor, all of these risk factors kind of need to be in the back recesses of our brain because all of them sort of play into this as well. Induction of labor is, by definition, where we take measures to start contractions before they spontaneously start on their own. Typically, inductions of labor we'll see for women that are post-due date, people that have had prolonged rupture of membranes, and we're worried about the infectious process, so we want to start labor. It's different than augmentation of labor, which is where we use very similar medications to enhance contractions that have already started on their own. We're trying to make them more effective. Indications for an induction of labor are going to be infection, that premature rupture of membranes, any kind of worsening medical disorder. So if mom's got those hypertensive states and we're starting to notice that we're heading down the road of preeclampsia, her body's not tolerating it, so long as she's not on the border of seizing, we can induce her and allow her to labor. IUGR is intrauterine growth restriction, so if baby's not growing well, oftentimes, or if they are growing okay and then they start to sort of drop off the growth curve, it tells us that they're not getting what they need from mom, and so they may be better off out than in. Post-term newborns and then fetal demise. Unfortunately, it's the only way to get mom's body to go into labor. Labor is, or I should say inductions of labor are completely contraindicated in several situations. If your patient has active genital herpes, we're not talking about somebody who's got a history of it, they have actual active lesions, that baby has to get delivered C-section because of the risk of transmitting that HSV infection now to baby and ending up with things like liver failure, HSV pneumonia, brain lesions, encephalopathy. I mean, there's a lot of negative side effects that come of delivering a child through an active lesion. Cephalopelvic disproportion, again, if that baby's too big to fit, we're not going to bother inducing labor. If mom has a prolapse or an unengaged presenting part, we're not going to induce her if that baby's not locked in and engaged. Placenta previas or a previous vertical uterine incision. They don't really do these typically anymore. They used to do what was called a traditional incision, which was a T, or just a vertical incision back 20, 30 years ago. Now the standard is that they do a very low-lying horizontal incision. It's much less tension on the uterus itself. So does that mean that if you have somebody with a placenta previa that they can't deliver vaginally? No, but it means that you're not going to go and induce their body into that situation. Methods that we use, cervical ripening, where they actually put hormonal stimulus onto the cervix to cause it to dilate in the face. They can do an AROM or an amniotomy, so they basically artificially rupture membranes. Prostaglandin gel, Cervidil, and Cytotec, those are a lot of what they do for cervical ripening, and it's usually a pill that they will place up and into the cervix that causes it to dilate. They may start oxytocin through an IV. It just sort of depends on the situation. During an induction of labor, it's going to be very similar to what we do for regular labor. We're going to monitor contractions, fetal heart rate, maternal blood pressure, vital signs, strict intake and output. Oxytocin can cause them to not diurese, and it causes water intoxication if we're not careful about their electrolytes. So something we definitely need to monitor for. We want to make sure that they're voiding appropriately. And then because of that, it can also cause this gradual elevation in their blood pressure because it causes them to retain fluid. People that are on oxytocin for several hours get very swollen. I was on oxytocin for 14 hours. I delivered an almost 8-pound baby, and when I came home from the hospital, I was 4 pounds less than I was when I went in. I delivered an 8-pound baby, a placenta, amniotic fluid. I should have been significantly less, but I was retaining so much fluid because of the oxytocin administration. These patients come out and their poor little toes are like sausages, and they'll tell you that their feet feel like they're going to split because they're so fluid overloaded from the oxytocin, from that retention of fluid, that their feet are literally just puffed. Oxytocin is discontinued immediately if we start to see things like blood pressure elevations, if they're not voiding. The doctor is notified if we're getting this uterine hyperstimulation, that's if they're getting too close together or they're lasting too long, or if we are getting non-reassuring fetal heart rate. So if baby is not tolerating labor, we're starting to see significant drops in heart rate not associated with the start of a contraction. You expect to see baby's heart rate come down a little bit with a contraction, because with a contraction we're getting that compression on the cord, right? So we expect their heart rate and their oxygen to go down a little bit. But the second that contraction releases, we expect to see a nice big acceleration in their heart rate as a recovery. If we're not seeing that, or if we're seeing drops in heart rate not with the contractions, now we're looking at a non-reassuring heart rate pattern. That tells us baby's not tolerating things. In any of those situations, you stop the oxytocin immediately, then you go notify your provider. Failure to dilate more than 2 centimeters in a 4-hour period. Again, that may be an indication for a C-section, but that doesn't necessarily mean it's a guarantee. They may sit on it and wait a little bit longer. They may try a couple of different things. They may rupture mom's water. They may give her an epidural. It just sort of depends, but it may be an indication for a C-section.
What's the GH?
Where?
Disorder.
Oh, gestational hypertension.
Okay.
It's again, one of those things that'll be in your hypertensive state. And DM is that diabetes mellitus. So operative obstetrics, we talked about an episiotomy already. It is performed to prevent tearing, shortening that second stage of labor. If, for example, you have a baby that is crowning and they're trying to deliver and mom's been pushing, and you're getting fetal head compression, so basically their head's getting squeezed too much, it'll cause that baby to drop their heart rate, and we need to get the baby out. So they will do an episiotomy to relieve the pressure to be able to get baby out. If you've got a baby that's delivering breech, or if they're using forceps, sometimes they'll use that as well just to make room. Afterwards, our role really boils down to providing comfort measures, because you can imagine that that's probably pretty painful. Sitz baths are a big one, ice packs for the first 12 hours. And then down the line, we want to make sure we're encouraging them to do those Kegel exercises to promote healing. Witch hazel pads, we use a ton, and those are designed to decrease swelling, and they work really, really well. Forceps deliveries, we did talk about this as well. It's that curved metal instrument. I think there's a picture of it on the next slide. The physician is the one that uses it. Typically, we need to make sure that, again, there's no cephalopelvic disproportion. That baby's got to be able to fit. Mom's got to be fully dilated in face. Her membranes have to be ruptured. Realistically, we're at the very end of the second stage. So all of this should already have happened. And we want to make sure she's got an empty bladder. If you have a baby that is getting stuck, is starting to show signs of dystocia, one of the interventions a physician may suggest to you would be to put in a Foley to make sure that mom's bladder is empty. Because at that point in time, she can't get up and go void, correct? You know, she's almost to the point where that baby's delivered. She's not going to be able to get up and go to the bathroom. So you may end up inserting a Foley catheter at that point in time. You can imagine how difficult that is. When there's a baby in the vaginal canal, everything is swollen, and now you have to find the urethra to put a catheter in. OB nurses are like the God's gift to female catheterization. It's it's impressive when you watch them do this kind of stuff. They're the people you want to learn from when it comes to putting Foleys in. You know, when you're out in practice, if you happen to have an opportunity to work side by side with an OB nurse, that's one of the top skills you want to ask them to teach you, because they're pretty remarkable about it. One of the things that we'll see with forceps deliveries are going to be bruising and edema of the fetal scalp. You can imagine if somebody's coming at you with clamps for your head and pulling, it's going to cause some trauma. We might see cephalohematomas, which we're going to talk about next week, intracranial hemorrhages. There's potential for brachial plexus injuries. That brachial plexus is the nerve system that runs along here. And you can imagine if somebody is grabbing on a baby's head and twerking to try to pull that kid out, there's a good chance that this is going to get stretched in the process. And so sometimes we'll see a temporary paralysis in the arm that's affected. It does get better over time, over the next couple of weeks, but it does take time to heal. Vacuum extractions are pretty brutal. They kind of terrify me as well. They are an alternative to forceps. We see these more than we do forceps nowadays. And what they do is they apply traction. So basically it's like a suction cup that goes onto the kid's head up in the vaginal canal. And as mom feels a contraction and goes to pull, the physician pulls with the vacuum to assist mom's efforts in pulling that baby out. Fetal complications can be cephalehematomas as well, lacerations. The scary part is they can end up with a subdural hematoma, though. And I've taken care of a kid that ended up with a ton, I think it was like 7 or 8 blood transfusions, something like 6 transfusions of platelets, FFP, a ton of stuff because he was basically bleeding out into that subdural space. So because of the high-risk component of that, fetal heart rate has to be monitored while they're doing the vacuum extraction.
So what's more, like, risky for these kids and moms? This kind of stuff, or just going for a C-section?
That's a good question.
Because when a C-section, you're a little bit more controlled than...
I can tell you, being a crazy NICU nurse who sees all of this scary stuff, when I went in, my birth plan consisted of 5 things, and I said, they're all no V's. I don't want a version. I don't want a vacuum. I don't want a VBAC. I don't want a, what's the 4th one? I can't remember what the 4th one was, and the 5th one was no vaginal destruction. Like, if I was going to end up with a complete 4th-degree laceration where 2 holes became 1, cut me open and take her out. Because as the NICU nurse that sees everything that goes wrong, I was terrified of all of these things. Does that mean that every vacuum extraction has that happen? No. I've been to plenty of vacuum deliveries where the kid comes out fine. But I've seen 1 in a million where it doesn't. So it's one of those where there's pros and cons to everything, and you're not ever going to get a solid answer on which one's better. C-section rates for a while swung one direction, and now they're kind of swinging the complete opposite direction, and I give it 10 more years, and it'll swing back the other way. It's kind of the way of medicine. But if you look at the picture, this is what a forceps delivery looks like. And so basically the blue color on the top is where they've clamped baby's head, and then they slide it in on the purple one and then pull back out. So you can kind of see it. It's not gentle. And as they slide in, you can kind of see they're basically pushing, they're like torquing on baby's head, basically, to get it down and up and underneath that pelvic pubic bone. Because you can see what they're trying to recreate is that external version, or sorry, the extension that we were talking about earlier. So it's when a baby gets stuck that's not doing that turn that they go in to try to help. But you can also understand why mom is at such a high risk for things like hematomas and tears and hemorrhage and infection, because this is not gentle on mom's system by any means. When you look at a vacuum, basically what they do is there's a couple of different kinds, but this one, I think this one's the key if I remember right, but this part goes up and into mom's vaginal canal, grabs onto baby's head, and then they pump it up to create the suction, and then when mom goes to have a contraction and she goes to push, they pull. And the suction on baby's head is what pulls baby through the track. So it has less of a damaging effect on mom because there's nothing hard traumatically inside of her, but you can also understand that it would create a whole lot of pressure on baby's scalp, which is where those bleeds come from. So a C-section, there's basically 4 indications for a guaranteed C-section. Dystocia, so that baby's not coming out, and now we're getting fetal compromise because that baby's not coming out. If they've had a previous C-section before, that would warrant scheduling a C-section. If baby's breech, or if there's any significant sign of fetal distress. Those would be the reasons we would go back for a C-section. The other things that we see it with, and they kind of tie in, that active herpes outbreak, prolapsed cords kind of linked together with that fetal distress, any kind of medical complications on mom that make her body intolerant to the laboring process, placental abnormalities, so things like an abruption or a placenta previa that's a complete, cephalopelvic disproportion, so if baby's too big, and then any kind of fetal anomalies. Although this, in practice, is starting to change. They're actually starting to deliver gastrosthesis babies vaginally, hydrocephalus kids, things like that. Yeah. They're starting to sort of swing the other direction, but for your tests, for your boards, fetal anomalies counts as a significant reason to schedule a C-section or to go in for a C-section. Management for a C-section, for our purposes, it's going to be your standard surgical pre- and post-op care. Managing pain, respiratory, that sort of stuff. We want to make sure that we're promoting involution, which is that contracting down of the uterus, potentially giving them oxytocin afterwards. They still get perineal care the same way. We still monitor their lochia, which is their output. Intake and output, we want to monitor for signs and symptoms of infection, give her psychological support through the process, and then depending on the reason for the C-section, she might qualify for a VBAC down the road. Alrighty, so now we're at the point where we have a baby that has delivered and we have a mom that's successfully delivered and everything is going smoothly. So the postpartum period is the point in time from when mom delivers baby until about 6 weeks afterwards, and that's about how long it takes her body to return back to its pre-pregnant state. That doesn't say pre-pregnant weight, just pre-pregnant state. Our goals really are going to be to assist her in recovery, identifying any kind of deviations from normal, educating her about self-care, newborn feeding, newborn care, that sort of stuff, making sure she's bonding appropriately with baby. The first 1 to 2 hours postpartum, our number one concern is bleeding. After that first 1 to 2 hours, our biggest concerns are bleeding and infection. But in that first 1 to 2 hours, your number one concern on that mom is bleeding. After those risk factors have passed, now we start to look at infection. So the uterus is going to change, obviously, because now there's no longer a human in it. And we expect for it to involute. Involute, by definition, means that it is contracting down and returning to its pre-pregnancy size and condition. We start with expelling the placenta. We get blood vessel compression because of those uterine contractions. And because that placenta is gone, now we no longer have estrogen and progesterone, right? Because those were the hormones that the placenta was secreting. So the endometrial lining starts to slough, just like it would at the end of a menstrual cycle. We start to see exfoliation, which is that the tissues basically necrose because they don't get the blood supply. And as they are necrose, now they slough off of where that placenta was attached to, leaving it smooth and nice and clean and ready to go for the next pregnancy. That takes about 6 weeks. Because that takes about 6 weeks, patients need to be told that they can expect to bleed for up to 6 weeks. The other part of it that we see that is very routine is the uterus descends into the pelvic cavity in a very routine fashion. Usually it progresses at about 1 centimeter or 1 finger breadth is the other way that we measure it, like this. This is a finger breadth. Into the pelvis per day. So somebody who's postpartum day 1, day after they deliver, you would expect to palpate that fundus 1 centimeter or 1 finger breadth below the level of their umbilicus. Because you remember, during delivery, after that baby's born, in that first 1 to 2 hours afterwards, we would expect to see that the fundus sitting at the umbilical site. Every day thereafter, it should decrease by 1 finger breadth or 1 centimeter. By about 10 days afterwards, you shouldn't be able to palpate it anymore because it should be down into the pelvic cavity enough. However, a full bladder can displace it. Usually it's off to the right side, and it can interfere with that process. So if you have a patient who you're not palpating their fundus midline, and they're 4 days postpartum, and you're feeling it at the umbilicus, what would your number one intervention be? Yeah, make them go pee. Because that would be your first step in evaluating where things are at as far as their uterus goes, encouraging them to void. Subinvolution is just a term, but by definition, it's where the uterus is failing to return to that pre-pregnancy state the way you would expect it to. In that situation, by 6 weeks, if it hasn't returned down to its pre-pregnancy state, your number one cause is now that there's retained placental fragments inside that uterus. And that's what's preventing it from completely contracting down. So your first sign in the early stages is going to be a full bladder. When you start to get out past that 10-day period, now we're really starting to worry about placental fragments. Reproductive changes. After pains are something that women are going to experience. They're normal. They're intermittent uterine contractions that are happening in those first 2 to 3 days because the uterus is trying to clamp down on those blood vessels. And typically, they feel them the most with breastfeeding because breastfeeding causes the release of oxytocin. Oxytocin is what causes that uterus to contract down. that's when they're going to be feeling the pain, typically after or during breastfeeding. Now that baby has been delivered, ibuprofen is completely safe for women to take, especially during breastfeeding, and it will help with the pain, the after pain. Lochia is the term they use for the vaginal discharge that we see. It's going to be comprised of blood to start with, for the most part, necrotic deciduous, so that lining of the uterus, and mucus. It's very important to distinguish it from a postpartum hemorrhage. Because what will happen oftentimes, especially in those first couple of days, if you have a patient that's lying down for excessive periods of time or sitting down for extensive periods of time, the uterus sits in like a arc in their pelvic cavity. Well, when they go to get up, that pelvis now tips up, as does the uterus. And so now when it's been sitting here like this, it's been pooling blood, and they stand up, and a whole big gush comes out. That's not a postpartum hemorrhage. That's a large volume of lochia that's been displaced all at once because of a positioning change, because of ambulation. Important to note the difference. I think there's a slide here with, we'll talk about that in just a second. The vagina itself usually is pretty bruised and edematous because of everything we just talked about, but does resume its pre-pregnant state usually by about 3 weeks postpartum. The perineum is also usually edematous and bruised. It's the site of your laceration or your episiotomy. Are you guys familiar with the Rita scale? Is that something you've learned in med-surg? It's just sort of a nice term for you guys to evaluate wounds in general, not just necessarily the episiotomy. Rita stands for redness, edema, ecchymosis or bruising, discharge, and wound approximation, or the edges nice and close together. It's just a nice, easy way for you guys to remember it. Pain in the perineum, again, like we talked about before, we've got those sitz baths, the witch hazel pads. They've got local anesthetic sprays that work really well. Dermaplast is one of the ones that we see used the most, and it's basically just a numbing spray that works really, really well for perineal pain. And then astringent pads they can use also. Lochia, this kind of gives you a
What's that water bottle? Is it
a peri bottle. Yeah. To help kind of with the sitz baths and just warm water in general. Lochia, in order for you guys to objectively measure it, this is sort of your best way to know how much volume you're looking at and how to describe it to your providers. A scant is a 2-inch stain, a small is a 4-inch stain. This is on the pad itself. Moderate is a 6-inch stain. Large is, it's pretty much the entire pad. And then if it's just saturated through the whole thing, it's usually more like 150 mils. So just so you guys have a way to objectify the values. Rubra is the first type of lochia you see. It's going to be very bright red. It lasts about 1 to 3 days, and usually it contains clots, and that's normal. Clots are very normal in the initial postpartum period, given that they're small. We define small as anything smaller than the size of an egg, usually, when we're talking to patients. Like if they're passing clots in the toilet and they're smaller than the size of an egg, it's fine. Anything larger than that is concerning because it's likely that there's retained placental fragments in there because the body's trying to continue to clot off and it can't. So the clot's getting bigger and bigger and bigger and bigger before it gets dislodged. And it may be that there are chunks of placental fragments in the clot itself. So typically what we end up doing is if it's larger than the size of an egg, we tell them not to flush it, and we have to go dig it out of the toilet and like pull on it to make sure that it's just a clot and not tissue. If it's tissue, that means they're going to have to go in and get those parts, whether it's through a DNC or going back and surgically removing it. Serosa is what we should see as the next progression, so it's going to pale a little bit, becoming pink to brown. At this point, after the 3-day mark, it should no longer contain clots. It can last anywhere from 3 days to 3 weeks, and then after that, it becomes lochia alba. And alba meaning white, it should be this kind of yellowish white color. Typically at this point it's mostly mucus, and this we'll see anywhere from 10 days postpartum to up to 6 weeks. After 3 to 4 weeks, if mom is still having significant volumes of bleeding, especially if it's rubra, it's probably related to the fact that uterus is not involuting appropriately, and we're looking at things like retained placental fragments. Any abnormal pattern at all should be reported. So if you have a patient that is progressing backwards, you've got somebody who went from rubra to serosa and now it's rubra again, not normal. Or if they've stayed in the rubra stage past our 3-day window, If you've got somebody who happens to end up in serosa early and ends up in ALBA early, it's not that big of a deal. It's just if you're starting to see it prolonged or they've started to get better and now they've stepped backwards, that is a problem. Musculoskeletal-wise, we don't have that relaxin anymore, so the pelvis returns back to its normal state usually within the first few days. Their muscle tone improves, but they tend to have a generalized there's a decrease in their bone mineralization because calcium is not absorbed appropriately the way it used to be, usually for about 18 months. So their bone structure in general can be weakened. So you can imagine people that get pregnant really close together are going to set themselves up for bone density.
Would working weights and that kind of stuff help with that infection?
No, there's really not much that changes it until everything hormonally returns back to normal. Cardio, and that's really about all you see musculoskeletal-wise. Everything basically returns to normal pretty darn quickly. Cardiac-wise, we do see a pretty dramatic and immediate change in order to prevent hypovolemia. Now, you remember we had that hemodilution of pregnancy, right? So we had a lot of excess to begin with. We get the elimination of the placenta, that uterus drops down in size. We now get a better blood flow back through the vena cava because we don't have that compression of the baby sitting on it anymore. We get mobilization of body fluids, so they're peeing a whole ton postpartum, trying to get rid of all of the excess that they've accumulated during the pregnancy. It is usually removed in two different ways. Typically, they're diuresing up to 3 liters per day, which is why they're peeing all the time. And they tend to diaphrese at night. So these are the patients that a week out are waking up drenched in sweat. I mean, literally drenched, like the sheets have to be changed. They're soaked. So bad. Not everybody diureses quite as significantly, but that's typically something that you see, especially with the hormonal shift. And as a result, you start to see an improvement in things like varicose veins, because now they're not distended with all of that extra volume. Vital signs and lab values. We should see a rise in hematocrit and hemoglobin, even though we lost all that blood, because a large portion of that blood is fluid that's not red blood cells. We're getting rid of all that extra volume, and so now, proportionally, we're no longer hemodiluted. Our hemoglobin and hematocrit actually should either stay the same or get better. If you have a patient that has a dramatic drop, or even a fairly minor drop in hemoglobin and hematocrit in the first 24 hours, that's a pretty big concern that they're actually hemorrhaging. Because if you're seeing a drop, it means that now they've lost all that extra fluid and they've lost red blood cells. Leukocytosis is normal. Usually it normalizes within about 10 days. It's normal to see an elevation in white blood cells postpartum within those first 10 days, even over 15,000. So we've got to watch for other signs and symptoms of infection because white blood cells are not going to be your #1 indicator. Clotting factors remain elevated. Fibrinogen usually normalizes within about 2 weeks. So we want to make sure that we're getting them up and walking because they're still at risk for DVTs and PEs. Orthostatic hypotension is normal because their body's still trying to figure out what to do with all of this cardiovascular shift. A slight temperature is normal for the first 24 hours because of dehydration and exertion and inflammation. So an elevation in temperature within the first 24 hours does not tell you they're infected. After 24 hours, it's a pretty good indication that there's an infection and absolutely needs to be reported. So that 24-hour marker for temperature is going to be a big one. A slight bradycardia is normal for the first 6 to 8 days because they do have all of that extra fluid on board, but their blood pressure should remain normal. If you have a patient that has a drop in heart rate, an elevation in heart rate and a drop in blood pressure, what are you worried about? Hemorrhage, because they're tachycardic because they've lost volume, and their blood pressure has dropped because they've lost volume. If you have a patient that's bradycardic, it's okay. Their blood pressure, regardless, needs to stay the same, and it just has to do with their body kind of trying to adjust to all of the extra fluid and getting rid of it. Urinary changes, their bladder has increased in capacity, it's lost some muscle tone, so their awareness of it being distended is limited, so we need to monitor for other things. The fundus being above the umbilicus or where it should be, displaced from midline if it's off to the right or to the left. If you're seeing a bulge above the symphysis pubis at all, odds are it's their bladder. if they've got any kind of tenderness over that bladder area, and if they're voiding frequently but not feeling like they're emptying, it's probably because they're not, and it has to do with bladder tone. That will get better, but what's our number one way to improve bladder tone? Kegels. GI-wise, constipation is not uncommon because people are afraid to poop. Their abdominal muscles have been totally stretched out, so it makes bearing down a whole lot easier. We've limited the food and fluid they've been allowed to take in. They are sore, they're swollen, a lot of times they've got hemorrhoids. So really making sure that you're pushing those stool softeners is a big one in the postpartum period. Endocrine changes, typically it takes a couple of weeks before ovulation returns. However, we do not have to see menstruation for a person to have ovulated, right? Menstruation happens after ovulation, which is why people can get pregnant even if they haven't had a menstrual cycle after they've given birth to somebody, because it's possible that they got pregnant the very first time they ovulated postpartum and they have yet to have had a menstrual cycle. Does that make sense? It happens. We've got a set of twins right now, and Mom's got an 8-month-old at home. They were born early, but she got pregnant pretty quickly afterwards. Non-lactating mothers resume normal ovulation and menstruation around 3 months, but that doesn't necessarily mean it can't be sooner. Engorgement typically happens on day 2 to 3 as the breasts become distended. They start to fill with milk and get warm to the touch. That's normal. Weight loss after delivery, usually it's a pretty immediate 10 to 13 pounds unless you're like me and have a ton of fluid on board. 5 to 8 pounds more are typically lost because of diuresis and diaphoresis, so a ton of extra fluid. And then 2 to 3 pounds during the first week is due to just blood loss and the uterus contracting down in size. I think we'll stop here and we'll start psychological changes next week.
If a mother becomes pregnant right after
Mm-hmm.
and she's still breastfeeding,
She can. Oftentimes being pregnant will inhibit the volume of milk she makes, and it will limit that factor. But yeah, it's not uncommon for those moms to continue to breastfeed. And we'll talk more about that when we get to the newborn stuff next week. But this is where we'll stop. Give me 1 second to find out. I think I should be able to. Sorry, guys. So if you want to stay, I probably have a couple minutes that we can go through a few of those questions. If you need to leave, that's fine too. Don't feel like it changes your, grade or perception or anything like that. Figure out how to get out of here. And then let me get the exam up. Okay, so the one caveat, if I'm going to bring this up, you can't look at the grades and be like, because they're going to probably change pretty drastically, because you'll see a graph that sort of shows where they are, which is the reason I don't post grades immediately. Okay, so the first one was, so we've got the gal who's in the first trimester with a BMI of 16.5. Which nutritional counseling should the nurse provide? I don't know that I'm going to change this one all that much. 44% of you guys got it right. She should be following a healthy diet with increased calories and calcium. But a fair amount of you guys picked the healthy diet high in protein and fat, and I kind of want to know why. If there's something that in your studying told you that, so I need to go back and look.
Mine was just not letting me BMI.
Okay. Okay. I was kind of wondering, because there's a question a little bit later that basically gives you this answer, short of the BMI concept. So that one probably won't change, but the next one, So a pregnant woman presents to the clinic at 16 weeks with lack of fetal movement. Ultrasound reveals fetal demise. How does the nurse document this pregnancy? Missed abortion is the correct one because because the baby has passed, but she hasn't passed any contact. Like she hasn't had any symptoms that has shown her she had an abortion. So the baby's passed already. And typically they have to go in and get induced in order to complete the process, but
Why would it not be what were the options from bleeding? No, because she could release or was it?
so missed is the correct one. Okay. I'm wondering if it sounds like I just didn't cover this well enough.
I thought like if there was no bleeding, then that would be like it's coming, like an abortion is you know what I mean?
Gotcha.
On its way.
And it can, with abortions in general, so like the majority of you guys picked inevitable. An inevitable one would be one where you still have a fetal, like the fetus hasn't passed yet. Like the fetus is still alive technically, but mom is having symptoms that would inevitably lead to her delivering the baby.
What were the options?
Threatened, it's not up here anymore. Threatened, inevitable, complete, and missed.
Okay, and I think I selected threatened because I thought when I was reading it said that there was no bleeding, but
Okay, so I think what I'll do on this one, because what it is telling me is that the few of you guys that did get this right did well on the exam. What I'll do is I'll turn it into a bonus question so that if you got it right, you'll get an extra point on it basically, and then if you didn't, it's like the whole exam will be out of 48 points. So I'll give you guys credit back if you got it wrong, pretty much. The next one after that, there was a huge streak where you guys did really well. And then, so a nursing assessment reveals heavy vaginal bleeding, a firm board-like abdomen, contractions lasting 3 minutes with less than 30 seconds between them, and uterine tenderness in a woman last assessed to be 3 centimeters dilated in early labor. What's your priority of care? Contact the physician would be your answer because what you have is an abruption in that situation. But looking at this, 75% of you guys picked frequent vital signs and fetal heart tones, and I want to know why.
because when we talk about it, it's always something you do before you call the physician. Yeah.
Okay.
Well, and
Like drilled into our heads.
Okay.
I think, didn't Mr. M or somebody say that it is never call the physician, there's always something else you do first?
Okay. Well, I will give you the caveat. When it comes to OB, there are times where you will call the physician immediately. Abruptions are definitely one of them because there's nothing you can do as a nurse to save what's going on. But given what you guys have been told in the past, what I'll do is I'll make that one into a bonus also and give you guys. So basically, if you've got it right, you'll get, again, kind of a boost, and then if you got it wrong, it'll sort of be negated. You can see why I don't go back and grade these right away. Which data collected during the assessment process caused the nurse to anticipate a diagnosis of endometriosis? You guys were kind of all over the place on this one. So, no, because in a normal cycle, people would have bloating. Fatigue, light menses, all of those are just signs you would see in general, not necessarily of endometriosis. Endometriosis is heavy bleeding, short time between cycles, and then pain, significant back pain because of the displaced material and stuff.
The tissue throughout the abdomen would be
Yeah, that's what I was
like
The
thinking.
bloating.
bloated all over.
Okay. I'm kind of on, yep. Yeah. Yeah. I'll kind of look into that one a little bit more. I'm sort of inclined to make that one into a bonus also, just.
Are you just going over the ones that most of us got wrong?
Yeah.
Oh, good. Okay.
Yeah.
Because I was sitting here thinking I got all of these wrong.
No, I'm like, I literally went through and anything that had less than like 45% of the class getting it right, I wrote them down. And that's about as far as I got. So, yeah, I'm only going through the ones that, like that last one, if I look, 25% of the class got it right. So that tells me that something went awry somewhere. What impacted moving birth to hospital? Oh, this one was on me, totally. Moving births to the hospitals in the early 20th century have on the rate of complications and death. It made it better, but it was a pretty slow decline. It wasn't rapid. It wasn't dramatic, but obviously a lot of you guys were feeling that way, and maybe that was on me from the first week. Yeah. So that one I will, again, it'll be a bonus. If you got it right, any of these, basically anytime I do it, if you guys have gotten it right, I'm not going to penalize you by negating it out. It'll only help you if you've gotten it right already, and then it kind of negates it out for everybody that got it wrong. The nurse reviews a woman's quad screen, which finding indicates a higher risk for Down syndrome in the fetus, and I think this one is probably going to stay as is because it's on the PowerPoint, and we talked about it in class. So with Down syndrome, you see a lower level of the alpha-fetoprotein. With neural tube defects, you see an elevated level, which is the one that a lot of you guys picked. With Down syndrome, what we do see is an elevation in the HCG level. So that one will probably stay as is because we did cover it in class. It was on the PowerPoint slide, but does that seem... So if they've got Down syndrome with the alpha-fetoprotein levels, they'd be low. If it was a neural tube defects, they'd be high. High. Mm-hmm. Yep. So I already know I'm making this one into I didn't make this into a bonus, but I gave you guys partial credit back depending. The nurse is caring for a woman who had a pre-pregnancy BMI of 22.3, has gained 53 pounds. Which assessments are most important for this patient? Select all that apply. Technically, the answers were serum glucose and blood pressure. That was it, because it was for this particular patient. So what are you going to look for specifically for this patient, not patients in general? However, those of you guys that also picked urine glucose, because that is something you would evaluate on this patient because you evaluate it on every patient, I did give you credit back if you picked serum glucose and blood pressure and nothing else. So if you picked those three, serum glucose, blood pressure, and urine glucose, I gave you credit.
Why would you not do urine glucose on this?
You would, but it wouldn't be specific to her situation. You would do it on everybody. Whereas,
but why would it not? I'm guessing, why would it not be specific to her situation?
Oh, so when you've got somebody who's got a BMI of 22.3, totally normal, has gained 53 pounds, you're trying to figure out why. Are they ending up with gestational diabetes? So we'd look at serum glucose. Are they ending up hypertensive and retaining fluid? We'd check blood pressure. That's what it's looking for. But because there's nothing that's like screaming that says, hey, I have a patient that has this, what would you do specific for that patient? I think it's kind of a vague question. That's not really fair. So if you're checking stuff that you would have checked on a normal visit for any patient, I gave you credit. So serum glucose, blood pressure, urine glucose. Because that's the only one that doesn't tie into what you would be looking for her, because every patient is likely to have urine glucose. The other two were premature rupture of membranes, because there's nothing in there that tells you she might have ruptured, and then fetal anomalies, because again, there's nothing that says that maternal weight gain has a correlation to fetal anomalies. Does that seem fair?
Yeah.
Okay.
So that makes me confused about the first BMI question, because wasn't she underweight?
Yep.
So then picking the fat one was good. You want them to eat fat.
But you want more calories. More calories and more protein, I think. You don't necessarily want to just give her fat, because it doesn't benefit the baby to have an excessive volume of fat. You want it to be a balance of increased supply.
I was from, I just ate that.
I chose fetal anomalies for that one too because I was thinking with gestational diabetes, how it leads to cardiac and how it leads to those fetal anomalies and how that's what we're assessing for.
I'll look at that. Okay. I'll look at that. And I might, if you've gotten the other three and picked that one, but kept the rest correct, I'll look at that one a little closer. Two more. Oh, so clearly this was on me, and it'll be a bonus, was the ranking the order of the That one.
So which one, okay, so I thought the egg was released before the hormone, is that
So,
not true?
no. The luteinizing hormone surge is what causes the egg to be released.
But in the PowerPoint, it says like, this phase doesn't start until the egg is released, so I kept that stuck in my
Gotcha.
head, so I think, yeah.
Like I said, I think that one, the fact that it was in the order it was in threw some of you guys off, and, yeah. I thought about that after I submitted it, too. I was like, oh, they're gonna hate me for that one. So I will go back and give credit on that, because that's...
Did I sit there and did that? 1, 2, 3, 4, that's right. That can be.
So then so 49 was the presenting part 1 that threw you guys off, and just knowing which way is positive and negative. Negatives above, positives below, completely counterintuitive. It is what it is.
The question was, where I think it was -2.
Yeah.
So you would have selected 2 centimeters suspended into the first cell.
Above the spine, the ischial spine.
What are you doing with that one?
Nothing, because it's,
Yeah.
yeah. And then, so the last one, I just wanted to talk to you guys about it more than anything. I don't think it'll change, but it's the 22-year-old that you've got with severe preeclampsia. They're being treated with magnesium sulfate. Which ones are the critical assessments for you guys to make when caring for them? Select all that apply. I think this one was just hard because it was select all that apply, and I know you guys love those. Deep tendon reflexes because of the magnesium. Blood pressure, again, because of the magnesium. But a fair amount of you guys picked temperature and back pain, and I'm not quite sure why, and I'm wondering if it's just because it was a select all that apply and it was there, so you clicked it because you felt like you had to. Deep tendon reflexes, blood pressure, back pain, temperature, and proteinuria. So it was deep tendon reflexes, blood pressure, and protein in the urine.
I didn't see the blue urine.
Because it, because with preeclampsia, it can cause renal damage, and so you'd end up with protein in the urine because the renal tissues are.
I think I read that, the other one like it was, what can I check, and I can't check that when somebody else checks that.
So you'd be assessing the lab value.
Yeah.
You know, what can I assess? What can I physically do right then and
Gotcha.
there?
Yeah, I think I'm going to kind of stick to that because you could look at lab values. But, so that one will probably stay. So there's 1, 2, 3, 4 for sure that will get credited back, and then one other one that I've got to kind of toy with. So by tonight, I would think you guys should have grades up. It might be like 10 p.m. tonight, but tonight. Okay. Yeah.